Well, good afternoon, everybody. I am excited to talk to y'all today about a topic that's very important really across the country, as inpatient hospital medicine not only is costly, but of course with COVID, everything, the systems have just been overwhelmed. So this is a very timely topic with our crowded emergency rooms and hospitals. So we're going to talk about frequent flyers, some stellar strategies for hospital super utilizers. I have nothing to disclose and no conflicts of interest. And so our learning objectives, we're going to identify what I mean by emergency department super utilizers. We're going to then discuss the methods employed to create what we call a community coordination care team, and then just explain the strategies overall to decrease ED visits and subsequent hospitalizations among ED super utilizers. Oh. Okay. So what do I mean by a super utilizer? So our hospital system found that less than 5% of patients take up more than 50% of hospital resources and healthcare expenditure. And so we developed what we termed a 5 for 50 program. So that's kind of the name of our program. And we utilize what's called that community coordination care team. So this very small population takes up all these resources. So why? So a lot of them have very complex chronic medical conditions that are difficult for them to manage in their own outpatient setting. They often have no medical home, so no primary care physician, no clinic, so they turn to the ER. These patients often also have lots of healthcare disparities, so they may not have income, transportation, they may be homeless. All these different things play into what makes them super utilizers. So as far as a definition, if you actually looked this up, there's no specific definition, but it's typically understood in the literature that if patients have more than 3 to 10 ED visits per year, then we consider them to be this super utilizer. And then it plays into the more they're in the ER, trying to manage their chronic medical conditions that really should be managed in the outpatient setting, then you can see how that in turn, if they're in the ER sick, then those turn into hospital admissions. So they initially present as ED super utilizers, but eventually all those patients become just hospital super utilizers. And as we know, the emergency department and inpatient hospital medicine is very expensive and not the best place for many of these patients. So how do we identify these super utilizers? So a few ways that we do it is we just look at, okay, who's utilizing your ED? Who are these quote unquote frequent flyers, super utilizers? So our EMR system, we use Epic at Integris, does have EMR flags, and you can easily look up their visits per year just by a click of a button. Our EMR also has, if they were recently in the hospital for an inpatient visit, and then they get discharged and they come back to the ER within 30 days, they have a little boomerang symbol next to their name. So that's very easily identified. In addition, we get referrals from physicians, nurses, and then the case managers will refer as well. And then the team looks through all those referrals on a monthly basis. So if I'm an ER physician and I know this patient is in the ER all the time, and I know, well, and I just think to myself, well, hey, if they were managing their diabetes appropriately outpatient, or if a nurse recognizes this, then they can refer to the program. Additionally, primary care providers, if you find out that you have patients and they're just frequently not coming to you for whatever reason, transportation, and so they call the ambulance, they call the ambulance to bring them to the hospital instead of coming to see you, then, you know, primary care physicians could also refer to hospital systems that have something like this in place. And, you know, you may see this just because obviously the ER, we're open 24/7, holidays, weekends. We don't look at insurance status, we treat everybody. So some patients, unfortunately, see this as their only access to healthcare. So although maybe they do have a primary care physician, instead of utilizing them, they utilize the ED, and that turns out more costly for all involved. So our program right here, you can see this little pie chart. So in our program, over the time frame that we evaluated this data that I'm going to show later, 53% had no insurance, 34% had Medicaid, 12% had Medicare, and then 3% had both. And there was about a quarter of those with no insurance that probably around 15%, less than a quarter, that when they entered the program, they didn't have insurance at all. But the case managers and our community care coordination team were able to set them up because they qualified for either Medicaid or Medicare. So that's important to note as well. 27 million are uninsured in the US. That's 14% of the population. So programs like this are very helpful to develop really across the country. And then when you do identify your super utilizers, you want to look at, well, what specifically is my population, these super utilizers, what are their particular healthcare disparities and disease population? So for example, at Integra Southwest, we have a very high Spanish speaking population. And so quite possibly some of them maybe show up in the ER because just of language issues and they can't communicate with the clinics or the primary care physicians. And so they end up in the ED, you know, and then we also have a pretty high homeless population, but just depending on your facility, you might have a different set of healthcare disparities. If your hospital is, you know, urban versus rural versus a community hospital. So once you identify the super utilizers, you're going to want to look at that at your specific population to see what your population's needs are. So why is this issue so important? Like I mentioned, emergency medicine and inpatient hospital medicine is very costly for all. So that's one reason, but so the Institute for Healthcare Improvement put out this triple aim, which is supposed to just overall better healthcare. So the goal is to improve the experience of care for individual patients, while at the same time improving care for the overall health of all the population, all while decreasing your per capita cost for healthcare. And so we aimed to develop this program to really address all these goals. And really, when you think about it, as providers, this really plays into our own wellness as well, because we all went into medicine to help people and we want it to cost as little as possible. and we want the whole population to be in better health, and we want our patients to experience good care. So if all these things are being met, then it's going to help with provider wellness as well. So what is a community care coordination team? So our team at Integra Southwest consists of one nurse practitioner, one RN, 2 social workers that really are also behaviorists and counselors, and they are really essentially like life coaches to our patients as well. And then we have a bilingual community health worker, since, as I mentioned, our population at Southwest is very high Spanish speaking. And then this team meets once a week and discusses their current patient load, discusses what is going well, what's not going well, what needs to be changed. And then once a month, they meet to kind of recruit new patients. So they get these referral lists from case managers, physicians, nurses, and they go through the list. There are a few exclusion criteria. One is dialysis patients they don't take. There are a couple others, but that's the main one. And they see if the patient would be a candidate, and then they look through, their records and see how many hospitalizations they've had, how many ER visits they've had, and they determine if the patient would be a good fit for the 5 for 50 program. And then they reach out to the patient, and it's a mutual decision. It's not, hey, Mr. John Smith, we see you've been in the ER a lot and that you've been admitted a lot, and you're joining our 5 for 50 program. That's not how it works. It's a mutual decision on both parties. And so that's how that part works. So then our key community partners are homeless shelters around the area, the health department, regional food bank, local transportation services, nursing homes for patients that require that level of care, free low-cost clinics, mental health services, and then the police department homeless outreach team, and then paramedics. So like I said, this team meets once a week, and then they meet with the community partners quarterly to, like I said, just check in, see what's going well, see what needs to be changed. And that's how that part of it works. Somewhat of a side note. So, of course, COVID affected everything, as we all know. But during COVID, we were able to develop a home O2 and remote monitoring program for COVID patients that we didn't think were too sick that they needed inpatient hospitalization. Then we were able to enroll patients in a remote monitoring program that they were sent home with a tablet that worked with or without Wi-Fi. So it would work even just with cell service. So a tablet, a pulse ox were the main things in there. And then if they qualified and needed oxygen, we didn't really want anybody in the program that needed more than 2 liters. But if they needed oxygen, then that was sent home with them as well. And we did have nurses. The patients were monitored via their tablet and had at least 1 visit with the provider every day. And then they had we had nurses from 8 a.m. to 8 p.m. monitoring their pulse ox and doing kind of spot checks. And so we did additionally have to get that equipment, but then our community care team was able to step in and work with this program as well. So we already had these people built in that could help out with our remote monitoring patients. And we had a lot of success with that. And we prevented a lot of hospitalizations when the hospitals were over capacity. So that was neat that we already had this CCC team in place to help with our other program. So what were some of the team interventions that took place? So the first one is just communication. These patients need lots of communication to know what's going on. They need lots of touches with the team. They haven't been able to really function on their own in the outpatient setting. So lots of communication goes on. I mean, I'll talk to the team members and they will literally be on the phone with them for an hour. So communication, and then education and coaching. So as physicians, we get so much education. We go to college, we go to med school, we do residencies, some of us do fellowships. So you get all this education. And then when our patients have something go wrong with them, we just sometimes assume they know more than they do, perhaps. So some of these patients just need really basic level education on managing their diabetes. How do I do a finger stick? What does this finger stick mean? If I get this finger stick, what do I do? How much insulin do I get? So just like I said, these team members are just amazing human beings, and they are really become more of life coaches to these patients for the time being that they're in the program. And you know, a lot of these patients just have a lot of healthcare disparities, and so they need the extra help, and the extra communication, education, and coaching to meet their needs. So let's talk kind of more specifically now about what our community care coordination team actually does for patients. So they have those weekly interdisciplinary care team meetings. And so they talk amongst themselves, check in, and then when they have meetings with patients, those are usually once a week as well. And so on these meetings with the patient, they initially have to establish expectations. So, you know, the goal, we explain to the patient that the goal is to keep you out of the ER and out of the hospital. So these are kind of our expectations for you. If you see that your blood sugar is 700, instead of calling the ambulance and going to the ER, then call our CCC team, call them. Don't pick up 911, freak out that my blood sugar is 700. So we establish expectations with the patient, and then they develop an individual care plan for that specific patient. So we do this approach to meet just the patient's specific needs. Are they homeless? Is their blood pressure the main problem? Is their blood sugar the main problem? What for this particular patient, what specific needs do they need? And then we try to establish a primary care home if the patient doesn't already have one. So while the patient is in the program, the team kind of becomes their primary care physician, but the ultimate goal is to establish them with a PCP so they have continued outpatient care after discharge from the program. And then the team is also able to kind of see the whole picture for the patient. You know, you may have a patient that has multiple physicians, so their pulmonologist is putting them on prednisone for their COPD, and then their family doctor is managing their diabetes that is being worsened because of the prednisone. So the CCC team is able to kind of get the whole picture connect with all of their physicians if they have multiple physicians, and kind of get everybody on the same page. And then time with the patient is just really, really, really key. Like I said, some of these visits are, whether it be in person or on the phone or on a tablet, virtually, some of these visits with these patients in the initial stages when they first join the program are 1 to 2 hours long. That would obviously not be feasible in an emergency department or a primary care physician's office. That's just not how the world works now. So these special patients need that special communication, education, and coaching, and that just takes time. And so the team is lucky to have that luxury of really all the time they need to be with the patient and go over everything with them. So we do have the patients sign a contract because, like I said, this is a mutual relationship and we want them to be on the same page and we want them to want changes for themselves. So if they aren't willing to get on board and sign the contract and agree with our expectations, then they're just not a good fit for the program. So we do have them sign a contract, and then they want to know the patient's goals. So what are your goals? Are you looking to get your blood sugar under control? Are you wanting to be more mobile? Are you wanting to quit smoking? What are your goals? Because we all are working together as a team to try and get you better health. And then you want to establish boundaries and set ground rules. So this is a specific patient example that the team told me about to kind of give you an example of this. There was a homeless patient who had a wound that was requiring a wound vac. Well, for a wound vac, you have to have electricity. Patient's homeless. And so the program was actually paying for him to stay in a hotel while he had his wound vac on to try to improve his wound. Well, the patient unfortunately took advantage of this, and he was actually taking his wound vac off while no one was around and inviting guests to stay with him in his hotel room. So, because he wanted his wound to not heal, so he could be in the hotel longer. So once the team kind of figured this out, they had to set some real good rules, say, you know, we're going to show up unannounced and you need to open the door within 30 seconds or we're going to have to dismiss you from the program. So there's definitely a lot of cases like that where the team just has to establish the boundaries, set the ground rules. And then everything they do is documented into our electronic medical record, which is really important because myself as an emergency physician, if a patient comes in, then I can pull up their chart and say, hey, they're in the 5 for 50 program. Why are they here for this? This is silly. We can even, if it's, you know, during daytime hours, we can even contact them and they might come to the ER and say, hey, this was kind of in our contract. And when we were talking about expectations, you weren't supposed to call the ambulance and come. You were supposed to call me. And everything, their individual care plans are documented in the EMR. Everything's in there. We can look to see, okay, they joined the program on this date. And oh, look, their ER visits did decrease. So why are you here today? So that's important that we have that documentation. So what are some of the specific patient healthcare disparities that the team tries to address? So they may not have a job, so they don't have any type of income. They may be homeless. They may not have a car or money to pay for bus or a cab. They may not have their necessary, medical supplies. They may not have the glucometer, the test strips, the lancets, all those things that they need to manage their medical issues at home. they may not have those things. Other social barriers are mental illness, which we see a lot, and that when patients have mental illness, it just makes it much difficult for them to just navigate the healthcare system. They may have substance abuse problems, addiction to drugs, tobacco, or alcohol. So those are kind of some of those disparities that we see quite commonly in our patient population. And so what resources does the team use to address these needs? Well, medication is a big one. When I talk about these hour phone calls, a lot of it, I think, has to do with medication, because often these patients with all their multiple chronic diseases are on multiple different medications that they take different times of the day, different dosages. Some of them may have drug-to-drug interactions. Some of them may have different side effects. So just all these things with the medication and the medication management, that takes a lot of their time explaining all that. As you all, I'm sure, know, maybe there's a medicine that will really help the patient, but it has a certain side effect, makes them nauseous, or it makes whatever it may be, and so they just stop taking it. When if they would address that with their physician or their provider, then we could give them tips like, well, maybe if you eat before taking the medicine, or different things like that. For those that do have mental illness, they're able to get them set up with counseling and mental health services. And then wound care, this is also a big one for our patient population. There's a lot of wounds that need to be dressed and cared for. And so our team is actually able to go out to their home, or when they're homeless or don't have a home, then sometimes we have a room in the ER that can be set up for that. There's also, as far as the homeless population, there is a service where the team can easily get them a government issued phone. And really that's almost a requirement of being in the program, just because the team needs to be able to communicate with you. However, there was one man they told me about that didn't want a phone for whatever reason, but didn't have a phone, but he was very motivated to be in the program. And so they got around that by scheduling their weekly meetings at a certain McDonald's that they went to at this time and this date every week. So that's another issue that some of our patients have, is the phone. And so they can help with that. And then other medical supplies that they may need for their diabetes or whatever they need for their medical supplies. And then transportation services. So they are able to give them bus passes, cab vouchers, and arrange for sooner ride for those that have Medicaid. So they help with that. And then there is a program that employees and volunteers those that know about this often do donate. And so they have a fund from donations that can be used to purchase kind of big ticket items like an electric wheelchair, an air conditioner, an air purifier. So they can luckily use those donations for some of those items when those are needed. So let's talk about some patient success stories of some patients that have been in our program and graduated and are doing well. So there was an elderly, like an 87-year-old female patient who had these multiple admissions and ER visits for chest pain. So, you have this elderly lady comes in for chest pain. We definitely need to work her up. And so she had these multiple admissions with nuclear medicine stress tests and cardiac catheterizations and echocardiograms and cardiac consultations and and all these visits and hospitalizations to try to figure out or rule out that her chest pain was caused by a cardiac cause. Well, she entered the program, and on the very first home visit with the CCC team, they discovered that she had this leaky faucet. And she would put this huge bucket under the leaky faucet, and that bucket would fill up with water. And multiple times a day, this little kind of frail elderly woman would pick up the bucket, go outside and dump it and bring it back. Well, once the team discovered she had this leak, they simply called a plumber who came to fix the leak, and her chest pain subsequently disappeared. So it was musculoskeletal chest pain caused by emptying her bucket. So the next patient was a 30-year-old with type 1 diabetes. He was a father of 4 children. He had multiple admissions for DKA. He also had uncontrolled hypertension, so he would get admitted for hypertensive urgency. He also had pretty bad dyslipidemia, and he had a job, but then because he wasn't managing his comorbid diseases well, he got an ulcer on a foot. He got an amputation. He was trying to not use his money on his insulin, so because he was just worried about his family and thought the money needed to go towards them. And so he would save up his insulin and only use it when he thought he was going into DKA. And so that's called creative non-adherence to insulin regimen. And so once he got into the program, then the community care team was able to help him pay for his medicines, help him get his diabetes, hypertension, and dyslipidemia all under control with his medications. He was given a bunch of education on his diabetes, and he was given food stamps and given education on healthy food choices. And once he got everything under control, he was actually able to get fitted for a prosthetic leg and then able to go back to work. So this is our program outcomes over a 3.5-year period that we measured. So prior to participation in the program, the patients had an average of 6.3 ED visits and 2.7 visits post-enrollment, yielding a mean difference of negative 3.6 visits. And then they had an average of 1.6 inpatient admissions pre-enrollment, which was reduced to 0.6 inpatient admissions post-enrollment, with a mean difference of negative 1.1 admissions. And prior to program enrollment, all the participants, all summed together, had 1,510 ED visits prior to enrollment and 882 visits post-enrollment, as well as 986 admissions pre-enrollment, which was reduced to 573 after enrollment, both yielding a 58% reduction. So a cost-benefit analysis showed that prior to program enrollment, it cost our institution close to $5.5 million to manage these patients. The total cost of the program over the 3.5 years was close to $1.3 million, and the post-enrollment cost to manage the patients was reduced to $1.6 million, yielding an overall cost avoidance of $2.5 million, which was a 46% reduction. So they do this on a frequent basis, but this was just one 3.5-year period that we evaluated, but the program is still ongoing. It didn't just end after the 3.5 years. and they do these types of analysis frequently. So some take-home points: super utilizers are a small group of patients with complex healthcare needs who account for frequent ED visits and frequent inpatient hospitalizations, thus consuming a very high percentage of healthcare costs. Programs such as our 5 for 50 program, who utilize community care coordination teams, can bridge gaps for these patients by making frequent face-to-face contact, coordinating their individual care plans, establishing follow-ups, and educating them on home management for their complex chronic medical conditions. So our program at Southwest is really a win-win-win, achieves all arms of the triple aim: better care for the individual, better overall health for the entire population, and lower per capita cost for healthcare. So community care programs such as our 5 for 50 program can significantly reduce health resource utilization and provides critical information needed to fix the significant national burden that ED superutilizers impose on the healthcare system. So this is our community care team, which does all the day-to-day work. So huge thank you to them. There's their titles below there. And then these are some of the other helpers with the program. And that is all I have. I'm available for questions. To take more? Quite possibly. I mean, because they, like I said, they do that list and but I don't know if they've just found that's kind of the sweet spot for, because I mean, there's a lot of patients that get contacted that have absolutely no want to do it. So that, I don't know if they have found with this amount of staff that works about just right for the patients that, number one, would be candidates, number two, qualify, and number three, are willing to be in the program. I'm not sure. I do know that our rural hospitals have a similar program, but it's not quite to this scale. And so in Grove and Miami, instead of the nurse practitioner doing a lot of the hands-on and the nurse, then they have, because the EMS system there are paid for by Integris, that the paramedics go out and do a lot of the face-to-face things. So they have expanded it to some rural hospitals too, and kind of got creative with how it's structured. So if they don't have a nurse practitioner, but they have these paramedics that could do some of the wound care and the different things, that's how those programs are structured. All right.
We do have one comment on our page that says that it does sound like a great program.
All right, we appreciate it. Thank you so much.
Yes.
Thank you, Dr. Keuchel. Thank you for having me. I just got back from Chicago day before yesterday, where we gave a talk at a convention about hospital at home. So it's exciting to kind of talk about our program, kind of what we've done at Integris, kind of why we've been successful, and just kind of introduce people to, what we think, what I think is kind of where, at least some form of hospitalized healthcare is headed, in the future, and kind of what we're doing now with that. So just a couple disclosure, like Dr. Keuchel said, I am the medical director for the Integris, one of the medical directors for the Integris Health at Home program. And then I'm discussing kind of the specifics of one kind of model of hospital at home, one that's kind of used through a consultant medically home. It's very popular around the country, and there are a lot of models similar, but there are other models that can, do hospital at home, and it's not, kind of the only way that this can be approached. So I just want to let people know that before we kind of jump in. So what we'll do today, we'll kind of understand the history, a little bit of what kind of home hospital care has been in the United States and, even around the world, discuss some of the benefits to hospital systems and patients, outline a successful model, and then we'll talk about, kind of a key part of that model, which is the patient acquisition process. How do we figure out which patients are good for the program? How do we get those patients into the program in general? So if we look at hospital at home, it really started internationally. So back in 1978, this is where we really started seeing the first kind of data for hospital at home really being submitted in journals and things like that. It's really started kind of in the UK, where they looked at kind of heart attack type patients, and they thought, well, is there a difference in if we treat some of these patients at home versus if we treat them at the hospital? And they started seeing, potential similarities in the data between those patients. Fast forward to 1990, we start seeing Canada looking at this type of potential program, looking at ways to offload burdened hospitals. In 1993, Australia started to investigate hospital at home models, trying to decrease costs for their hospitalized patients. And then in 2003, Australia even went a step further. So they were dealing with a lot of issues with private payers in Australia, saying that, we didn't necessarily want to cover hospital at home as an option for our patients, something that we're seeing now in the United States. So what they did is their government actually came together, and they basically redefined what hospital care was, and they made hospital at home legally, kind of under the umbrella of all hospital care. So payers didn't have the option of excluding hospital at home specifically for their patients in 2003. In the United States, what we've seen, starting really in 1995 is when we start seeing kind of investigation at a hospital at home here stateside. And Johns Hopkins was kind of one of the first to really start delving into this, looking at ways to deliver hospital care at home based on some of the data that they'd seen from the UK and Canada, places like that. In 1998, there was a study, one of the first in the US, is 17 patients, done a hospital at home program, and showed that, the program was feasible, it was safe, it was cost effective. Those are the really big things that they were trying to determine. Fast forward to 2002, many more studies had been done showing success and benefits of the program. Some of these, we'll look at some slides with some more specific data, but these are things like shorter length of stay, overall cost reduction, reduced readmissions, things like that. And then in 2010, they looked at the first kind of studies using, as the technology has advanced at that point, biometrically enhanced two-way telemedicine kind of communication with video and things like that, and how that could enhance hospital at home. And obviously, since then, we've come a long way. So right now, there are hospital at home waivers, which at the start of the pandemic is really when things started to jump off, oh my goodness, here in the United States a little bit more. And Medicare developed a waiver program for hospital at home in order to actually pay for it. Prior to the pandemic, prior to kind of mid-2020, there really wasn't any way to get paid as a hospital or a health system for providing a hospital at home program. Places like Johns Hopkins were really doing it based on grants and based on kind of research to kind of prove it as a concept here in the United States. But since then, 36 states, 110 health systems, and 245 hospitals are using some form of hospital at home waiver and providing that kind of care for their patients. If we look at this data here, this is kind of looking at what kind of patients are getting that care. Mostly Medicare and some Medicaid. And this keeps wanting to jump forward, apparently. I'm trying to go back. There we go. And this is basically over a period of time up until December of 2021, there were about almost 2,000 patients, goodness, treated with under hospital at home. And you can see here, this data here is mostly about return to the hospital and how many of them really had to leave the hospital at home program and go back into the hospital for other care. And it was about 8%, which is really great data. Like I said, I'm going to talk about, this keeps jumping forward. I'm going to talk about Medically Home a little bit. And this is a partner that we work with. They're really founded in 2008 after the founder had a kind of adverse kind of hospital experience with his mother. She was experiencing, chronic medical issues and problems that kept her in and out of the hospital. And it's got him thinking, is there a different way that she can receive this type of healthcare rather than having to go in and out of the hospital all the time? It's really hard on her every time she has to go in. What can we do about this, here in the United States to potentially provide some type of different solution? So he went through the design period, went through the testing and publishing of clinical trials. And in 2007, they really published and kind of started with their first partner, which was Atrius Health. And since then, you can see that they've got markets kind of around the country, command centers anywhere from Mayo Clinic, Kaiser Permanente, even Cleveland Clinic is developing a hospital at home program with Medically Home as well. And then you can see our program there, Oklahoma City, right in the middle, as the only program here in the Oklahoma area providing hospital at home. So, why would you think about offering a hospital at home program, right? Well, really, when they're starting to look at what we're being pushed towards from a kind of health system standpoint, we look at some of this data and it says by 2020, healthcare organizations plan to invest most of their money in home health, palliative care, and geriatric caretakers, right? Hospitals, they're experiencing increased volumes, and we definitely saw that over the pandemic where hospitals were 90, 95, 100% capacity for long periods of time. And really, since the pandemic has somewhat subsided, we're still seeing high volumes of patients dealing with chronic medical problems, patients having difficulty controlling those problems at home. And we're still experiencing med-surg divert, ER divert problems, and difficulty getting those patients into the hospital, into those beds where they can really receive the care that they need. So there's really a call to action, right? So can we provide, improve quality and safety for patients? Can we decrease cost through reduction, in the ways that we deliver care? And can we improve satisfaction for patients? And can we do those things in a way that allows us to get those patients or some of those patients out of the hospital system so we can free up beds for other patients? So if we look at overall benefits of virtual hospital care to patients, we see things that are improved. Patient satisfaction is one of the biggest things that is improved. Patients like being at home, right? A lot of people wait too long to come into the hospital in general because they like being at home. Patients sometimes leave the hospital too soon because they like being at home. They want to be with their pets. They want to be with their family members. They want to sleep in their own bed, eat their own meals. All those things, they can do in a hospital at home type program. It's, improves rest for patients and caregivers. Patients sleep better in their own beds. Caregivers, can know that their family's being well taken care of. They can be engaged in the family member's care. They can join in those visits and be more present for therapy, for medication administration, for education on the disease processes. And overall, the patient perceives their quality of life better because they're not stuck in a hospital bed. They're not lonely in a hospital room where they don't get visited as much. Things that it reduces readmissions in some studies by, up to 8 to almost 10%. Mortality in these patients, cost as well, decreased hospital-acquired conditions, falls, and delirium, and then overall deterioration in the patient functional status, which we'll see is a decrease in SNF utilization in patients that have gone through the program as well. So this is some data here. The one on the left, left is from, I think this is from, Johns Hopkins in 2005, basically looked at 2 different sets of patients. And a lot of times when people see data on hospital at home, they say, well, patients in the hospital are sicker than the patients that are doing, hospital at home type programs, right? So obviously the data is going to, be skewed towards those hospital at home patients, but this data specifically was an apples to apples comparison, meaning that, it was the same acuity level of patient that they looked at that was in the hospital versus one that did a hospital at home type program. You can see the length of stay was less, cost was reduced by about a third, and decreased amount of falls. The next study here you can look at, obviously we're still seeing reduced length of stay. Readmissions are decreased almost half, ER visits less, overall experience is higher, and as I mentioned before, decreased SNF utilization. This is kind of a meta-analysis here of several different hospital at home programs, almost 1,000 patients. And this was published in JAMA in 2021. And it shows similar data here, right? Decreased SNF from 9.7 to 0.6. Anxiety was improved, and readmission for all cause was down about 25% compared to non-hospital at home programs. So what does a hospital at home program look like, right? What does it provide? This is kind of an overview of our program at Integris. We went live with programs accepting patients from Integris Baptist and Southwest on January 31st of this year. And then we expanded on June 6th to include Integris Edmond and Integris Canadian Valley. So we're now live at 4 different hospitals. Basically, we take patients one of 2 different ways. They can either be admitted directly from the emergency department, or they can be somebody that's already in the brick and mortar hospital in inpatient status, and they can be transferred into the hospital at home program. Right now, hospital at home in general is under the Medicare CMS waiver. That waiver does require the patient to be seen in an emergency department before they're allowed to be admitted to the program. Definitely the future of where this is going to involve things like direct admissions from maybe a specialist or a primary care physician office. Instead of potentially needing to send someone to the ER, they could be directly admitted, from the office if, they met the right criteria. So I think that once we're able to move past the CMS waiver, we've got a lot of opportunity to decrease, potential ER utilization even further. Active payers right now, obviously, like I said, we're operating under the CMS waiver. So we have Medicare. Here in Oklahoma, we've actually been able to partner with our Medicaid program, which hasn't happened in other states and all the other states. Some states have been able to do it, but here we've had a lot of success with our Medicaid population. Probably about 35 to 40% of all the patients that we've taken over the last 7 months have been Medicaid patients. A lot of times those patients, as Dr. Shipman talked about before, really have decreased access to post-discharge services and post-discharge, assistance because of that Medicaid status. We're also taking some Medicare Advantage plans, United, Community Care, AARP, and obviously our Integris insurance. We are, in active communications and conversations with, some of the other commercial payers as well, and feel pretty confident about the future of those relationships. Our target population right now, obviously, the patients have to be meet inpatient criteria. So we're not doing any observation patients. They have to be full inpatient status in the hospital. But we hope to expand to observation patients soon. And then we are, obviously, like I said, we have to either take them from the emergency department or the inpatient part of the hospital. You can see over on the right-hand side, we've got a map. It's kind of just a view of kind of our radius. One of the requirements under the CMS waiver is that the patient live within 30 miles of a referring facility. That does a couple things. Number one, it allows to make sure that we have a service provider network that can provide in-home services for those patients within a certain area. And it also allows us to be able to potentially return the patient to a hospital in the event of some type of deterioration and do it in a relatively, short period of time. We opened in January originally with a 10-bed capacity and have expanded up to 15 beds as of April, looking to move up to 20 and then 25 beds capacity by the start of the new year. So who is it that works in a hospital at home program? Right now, we are staffed by Integris Health hospitalists, and they're the physicians that really are seeing the patient on a day-to-day basis. Now, the hospitalists don't see the patient in physical person. The hospitalists use our technology kit, which I'll go through here in a couple of slides, to do video visits with the patient on a daily basis. They will round on their list of patients, the same as we would in the brick and mortar hospital. We review their labs on Epic. They show up in our electronic medical record the same way that they would if they were in the hospital. And we're able to place orders, medications, check labs, imaging, all very similar to the way that we would do if they're actually in the hospital. And so we will round on them, and we're available to, be able to send links to participate in that video visit to family members, other specialists, primary care physicians, and anybody, in the care team that really wants to be involved in those types of discussions, allowing a really broad range of kind of interdisciplinary care for the patients. So the registered nurses are also working in our command center. They see the patient on the same frequency as they would in the brick and mortar facility. They see them about every 4 hours or so, sometimes more. They're on the video with the patients when they take their medications. They check in and out all of the caregivers that are providing care for the home, whether that be wound care, medication, IV medication administration, PICC line placement, x-rays, all of those things. The registered nurse is really the quarterback of how the patient is receiving that care in the home. And they do that via our command center and with video visits with the patient as well. We have nurse practitioners that work with our program, and they actually provide in-home visits to the patient. So they'll go on hospital days 1 and 3 to actually visit the patient's home, and they'll do environmental assessments on the home to see, what kind of safety features are there, what kind of safety hazards may be in the patient's home. They'll also do kind of an enhanced social screening on the patient, trying to determine what those social determinants of care are for these patients and what we can do to help decrease those risks and help prevent readmissions to the hospital. They're also available to kind of be our hands and our eyes and our ears in the patient home directly whenever we're doing our video visits with the patient. A lot of times we like to do our visits with the nurse practitioner there so that they can auscultate, so that they can help us view wounds and things like that. Provides, a really comprehensive visit for us to kind of do our rounding and our patient encounters also. And then we have service coordinators who aren't actually here in person. They're actually out of Boston, and they're medically home employees. But what they do is they help logistically set up all of the access that's going into the patient's home. If we place an order for labs to be drawn, we have several redundancies of companies that can draw the labs, and they're involved with scheduling and coordinating which company makes the most sense to come in and actually draw those labs for the patient. So kind of a robust team involved in taking care of the patients. This is kind of a snapshot of kind of our model here. On the left-hand side, you see our command center where we have our physicians, our nurses, and our nurse practitioners. On the right-hand side is our rapid response services. So this is everything that goes into the home. And like I said, we can provide most anything that we can have in the hospital. So we have home health nurses, we have community paramedics that provide a lot of our services, whether that be wound care, wound vac changes, IV medication administration. We have oxygen, DME delivery services. We can provide meals, mobile imaging, labs, home health aides, PT, OT, speech, all that kind of stuff is available, and we bring it into the home. And in the middle there, you see it's kind of all connected. We still use our same EMR, like I said, exactly the same. Everyone's documenting the same as we would if it were in the hospital. And the platform that really connects what's happening in the home to what we're doing on our end in the EMR is a program that Medically Home put together called Stacia, which really helps us, number one, connect to the patients via video and phone. And it also kind of helps track the logistics of all of that care that's going into the home. So this is some of the technology that we're looking at that's in the home. We have a tablet, which if you look on the left-hand side is kind of a mock-up of what that tablet screen looks like for the patient. A lot of people that need, hospital level services may not be the best at technology, but we have made it pretty easy to where we feel like even our most technology challenged patients have been pretty comfortable being able to use this technology. So not only do the patients get to see, have an easy way to communicate with their team, but they get to see their schedule. If you're hospitalized in the hospital, you're sleeping and all of a sudden somebody wakes you up because it's their, time to round, or now it's time for your medication. You never really know what time anything's going to happen. Well, with our program, with the platform that we have, the patients are able to see their schedule of who's coming into their home, what time it is, and what services they're going to provide when they're there, which is really great for patient satisfaction, preventing surprises, and allowing them to know and kind of plan out their day from that standpoint. There's an easy button that just says talk to my team. You press that button and it directly starts a video call with your nurse. So it's really easy to get a hold of them that way. They're also able to upload pictures, check vital signs, and view education from the tablet, and it's all very easy. We also have a lot of biometric equipment that's in the home, and these provide Bluetooth linking to the tablet. So patients are able to check blood pressure, pulse ox, and we have a scale that can check weight, and all of that is automatically uploaded to the tablet, which is then synced to their Epic record. We also kind of have a triple redundancy with communication to the patient. So like I said, we have the tablet, which is one way that we like to do most of our visits, but we also don't want to invade the patient's privacy by popping in on a video visit when they may not be ready for it. So we have a phone that we've provided to the patient that actually uses Wi-Fi services. If the patient picks it up, they don't have to dial any numbers. It just connects directly to the command center and to their nurse without them having to really do much of anything. We also usually call them on that phone as our primary method of communication before initiating a video call or anything like that. You also see the little white box and what looks like a little kind of wristwatch. That's actually an emergency button that the patient can wear as a watch or as a lanyard necklace. And that allows them to get more immediate or expedited or triaged kind of answering of any phone calls or needs if there is some type of emergency. It rings through differently on our system so that we know that this call is, one of the emergency calls and not, a phone call or a video call from that standpoint. And it also, just helps provide a level of kind of safety and security for the patient. It's waterproof, so it can go in the shower or the tub so that they can wear it at all times when they're in their home. They don't have to worry about taking it off. And then you see a router. We actually provide, sometimes we'll use patients' Wi-Fi, but, we don't want that to be an exclusion for us to be able to provide care to our patients. So we actually provide a Wi-Fi or a cellular-based router into all of our patients' homes so that we can have reliable internet to be able to connect all of our devices to kind of our command center. So this is just kind of an overview of our program kind of clinically. Like I mentioned before, we have two ways of obtaining patients, either through the emergency department, which we call hospital substitution, because they're coming to us, they're not, instead of going into the hospital, or patients that are already in the hospital and we transfer them out, which we call reduced length of stay. Things that they need to have, we talked about, we can talk about qualifying DRGs, and honestly, there's not really a DRG that is excluded, based on insurance criteria. Obviously, we have some that are more common, and I'll show you a slide here in a few that kind of shows you all kind of our 40 or 50 kind of first diagnosis from like our first kind of 40 or 50 patients and which ones that we're seeing. And you can kind of see trends of which diagnoses are more common for patients that we treat with our hospital at home program. I mentioned before, they need to be inpatient criteria. And then they have to meet pass a couple of stability screenings. There's a clinical stability screening, which we'll walk through, and a social stability screening. Obviously, they have to give consent and want to participate in the program, and then they have to be within that 30-mile radius. Right now, we are active with what we call the acute phase, which is basically just substituting their inpatient hospital stay, whether that be directly from the ER or as a transfer once they've stabilized. It provides inpatient level care. It's physician led. The hospitalists are the one kind of managing that care plan on a daily basis. They're receiving nurses visits and therapies, usually at least 4 times a day. They have frequent visits with their clinician, which in the acute phase is the hospitalist, and that's at least once a day. And then on day 1 and day 3 with the nurse practitioners, we can do in-home diagnostics. And this is really where we're substituting their hospital stay. We're also moving towards the development of what we call a restorative phase, which we'll go live with in January. And this is really where the rubber meets the road from a standpoint of seeing that data that we talked about earlier with reduced readmissions and that kind of thing. This allows us to have the patient for a 30-day episode within our program, where that will include whatever period is their acute hospital stay. Right now, our length of stay is about 5.5 days or so. So that leaves us with a remaining 24-ish days potentially to provide that type of education on chronic disease processes. We can really monitor how the patients are providing their own care. They can still leave the home and go to primary care visits, specialist visits, and it just allows us to develop more of a relationship with them over a period of time where we can really see what it is that would have prevented them to go or would have made them go back into the hospital, and allows us to prevent those episodes and keep them out of the ERs and out of the acute hospital stays. The restorative care phase is really, it's APP led, and it's going to be the nurse practitioners that are kind of managing the patients during that phase. It's also designed to potentially be a SNF substitution phase, so more heavy into physical therapy and rehabilitation as well. And then they work on medication management, like I said, patient education, and gradual transition back to the primary care physician as the kind of leader once either the 30 days has elapsed or we feel confident that the patient is in a good place from a healthcare plan standpoint. And then obviously after that 30 days, they continue their ongoing management with their primary care physician or their specialist. We obviously want to do a warm handoff from our nurse practitioner to the primary care doctor, just letting them know, what we've done, kind of how the patient is done under our care, and hopefully they have a new stable baseline. So we'll talk a little bit about patient acquisition. It's probably been one of the most difficult aspects of kind of our program is determining what patients and getting those patients in. In a hospital, obviously we don't have problems getting patients. The problem is we have too many patients, right? That's why programs like this exist, is there's too many patients walking in the door, too many people are sick, and the hospitals don't have to do anything. They don't have to go actively search for those patients. The patients just show up. Unfortunately for us, it's not the case. People don't just show up at the door of hospital at home wanting to be admitted, at least not yet. And so we have to try to find those patients. And so this is part of how we do that, and part of how we make sure that we're finding the right patients that we can safely and adequately pay or provide care for. Because I think that, a lot of people, when they first hear about hospital at home, their concerns are, is it safe, right? That's why all those studies in the beginning were trying to determine, is it safe? Can we provide safe care for our patients? And I think that's what we as physicians want to do, is make sure that we provide care that will make our patients safer and healthier. And we don't want to do things that's going to jeopardize that. And this is what kind of our acquisition process helps us to determine. So like I said, obviously they have to meet inpatient criteria, and they have to pass a couple of stability screens. The first is the social stability screening. The social stability screening helps determine a couple of things. One is the patient's home or their place of residence safe for them to receive care? So we've been into many patients' homes, and sometimes patients don't necessarily realize how bad their home situation is, right? They think it's okay. They've lived there for a long time, but you get in there and there's dog feces on the floor. They live with 37 cats, and maybe they have holes in their walls, and it's the winter time, and their heat doesn't work, or it's summer in Oklahoma where it's 100 degrees for a whole month and they don't have air conditioning. Those are things that we try to determine based on that social stability screening. We want to make sure that this is a safe place for the patient to heal. We also want to make sure it's a safe place for us to send caregivers to, right? Because we're taking our caregivers and we're putting them in the patient's home. We want to make sure they don't have violent and aggressive pets. We want to make sure that they, don't have, a bunch of weapons sitting around everywhere that are going to be potentially a threat to our caregivers. We know that sometimes situations between patients and caregivers can, escalate if we have differing opinions on how things are, should be done for that patient. So we want to make sure it's safe for the patient, safe for our caregivers. That's the big thing on the social stability screening. We also determine things that may help us in taking care of them, some of their needs from an ambulation standpoint, if they need meals, some of those more specifics we determine during that process. And then we do a clinical stability screening. The clinical stability screen helps us to determine that the patient is safe to go home from a clinical standpoint. So this is done in a combination of a hospitalist doing a chart review on the patient from the electronic medical record, as well as having a conversation and talking directly to the patient's attending physician in the hospital. So we try and determine that the patient is clinically stable from a vital sign standpoint, right? We want to make sure that they're not deteriorating. That's not a patient that we want to take out of the hospital environment and continue their care at home. We want to make sure that they're not on any type of intervention that we can't provide. Things like vasoactive drips, you know, if they're requiring vasopressors or intubated, obviously that's not a patient that we're going to take. We're not going to take, you know, patients that need a procedure that day. If they're going to need surgery, obviously we're not going to be taking them home. And if they need in-person specialty consultations where there's a surgeon maybe managing that wound on a daily basis, you know, and really providing direct oversight, that's going to be somebody that is potentially going to stay in the hospital. There's also some other conditions and kind of circumstances that at this point are kind of not red flags, but just kind of hard no's of things that we can't do. That's patients that live in a nursing home. And unfortunately, you know, if they're using their insurance to pay for their residence, as in a nursing home, we can't also use their insurance to pay for their hospitalization in the same place. So nursing home residents are excluded. At this point, we're also not doing dialysis patients. Patients that have active substance abuse, that would be somebody that would be in a home environment that would not be safe for them, obviously. And then patients that maybe need one-on-one or really significant care to perform their activities of daily living. That's going to be somebody that's probably going to be too resource intensive for us to take care of in the home environment and would probably be safer in the hospital setting. And then patients that have some type of need for a one-on-one sitter precaution, maybe suicidal ideation or something like that, is going to be something that we wouldn't take as well. And then obviously patients that say no or don't want to participate in the program. Obviously, we're not forcing anyone to participate here. We want to make sure that we explain the program well and gain the patient's trust in doing this program, but obviously it's up to the patient. So generally, if we're looking at a pool of patients, anybody who meets inpatient criteria, who is, you know, sick enough to be in the hospital, but does not have one of those few things that we mentioned, could potentially be, depending on their other factors, an eligible patient for hospital at home. So this is a list, kind of our first 40 or so, I think there's more than 40 on this list, of diagnoses that we've taken. You'll see a lot of infectious related complaints here, and I think that those are some of our more common, things like pneumonia. Patient maybe comes in with a multifocal pneumonia, needs 3 or 4 liters of oxygen, some IV antibiotics. It's a perfect patient for hospital at home. We can do up to 6 or 7 liters of oxygen safely at home. We provide concentrators that go up to 10 for backup purposes in case the patient decompensates or has a you know, some type of decline. But we can do lots of different IV antibiotic regimens at home without any problem. Cellulitis, COPD exacerbation, you know, if they need TID IV steroids, definitely something that we do all the time from our standpoint. CHF exacerbation, IV Lasix therapy at home, monitor their potassium, replace potassium if needed. We can even consult the cardiologist or the pulmonologist and have them do video visits with the patient as a specialty consult, just like they would in the hospital. Same with our infectious patients. We've worked a lot with our infectious disease specialists from our inpatient hospitals, and they are seeing these patients, helping manage their antibiotic course, watching their cultures, reculturing if necessary. And then, you know, once we kind of have our plan together, we can discharge that patient with home health or some other service, and they can complete that course, you know, once we've kind of completed their plan of care from that standpoint. We've even done things like TPN in the home, you know, which was pretty exciting from a access standpoint. And we're working on, you know, building out our ability to do kind of more things safely for patients. But you see, there's a lot of different things that we've done. A lot of it has been infection related, but definitely other things as well. We were relatively COVID heavy to begin. Obviously, that's backed off a little bit, but we're excited about kind of where, you know, where the future is and where we can go as far as what kind of patients we can take care of. So, you know, a question that a lot of people have when they talk about hospital at home is what happens when the patient declines, right? What are we going to do with a patient that is at home, you know, 15 miles from the hospital, when they start having some type of, you know, problem and they start decompensating? Number one is to plan for it, right? These are not, it's not impossible or unexpected that the patients are going to have decline. Patients in the hospital decline all the time, need IMC or ICU level care when we necessarily wouldn't have expected it. This patient that may seem like they're going to have a perfectly smooth course sometimes has a problem that comes up that we couldn't have expected. And that happens. And it doesn't necessarily happen just because the patient's in a hospital at home type environment. It happens in the brick and mortar hospital too. The data that we see from around the country, we saw that initial data said about 8%. Really, we see about 12% or so of patients in hospital at home programs have some type of decline or decompensation that requires return to the brick and mortar hospital. So, what we do is we look to make sure that we are within those guidelines or within those bounds. And you'll see on the next slide, we kind of have some of our metrics, and we are, within that and doing a good job from that standpoint. So when you plan for it, what do? You make a plan for how to get that patient taken care of and in the right environment in a timely and expedited manner and safely, right? So what we've done is we've built a process where we can get the patient automatically accepted into the hospital without having to go through the formal process of calling the transfer center and waiting for the hospitalist to call us back and talking to the attending physician and having them accept. And then we wait for a bed and we see if the house supervisor even has a bed available. And then they get put in line to potentially, get in bed when it comes available after they get the ER cleared out. We've skipped all of that. So what we do is we call the transfer center and we tell them we have a patient that needs to go back to the hospital. And that patient is just automatically accepted to the hospital without any conversation with the physician, because these patients are already inpatients of whichever hospital they came from, right? We're taking care of inpatients in the hospital. So in our hospital system, if the patient came from Southwest Medical Center and they transferred out as a Southwest Medical Center hospital at home patient, in the computer system and in the hospital system, they're still viewed as a Southwest Medical Center patient, almost as if the hospital at home were just a different floor of the hospital, right? The hospital at home is the 11th floor, right? So these patients are all on the 11th floor of the hospital. And if you have a patient on the floor of the hospital and they're declining, what you do is you transfer them downstairs to the IMC or to the ICU. And that's what we do with our patients, is we don't need them to be accepted anywhere. We don't need to talk to anyone about it, because the patients are already being taken care of in a hospital setting. And so we just transfer them to the desired destination. Initially, before we really had this process in place, it could take up to a couple of hours to really get a patient from first phone call to the transfer center to having a bed and moving them out. Could take a few hours. With the process that we've put in place, it's really been consistent that we can get the patient accepted to a bed in the hospital and on the way out the door in about 20 to 30 minutes. And we can get someone to the home to provide more rapid assessment and care for the patient in about 10 minutes. And so that's really where we're looking at providing that care for patients. Obviously, if patients have some type of need that they necessitate immediate return to the hospital, having an active heart attack, an active stroke, really decompensating in a way that we can't wait for that 20 to 30 minutes to transfer them back into the hospital, then we can always call EMS and have them brought back into the emergency department at that point. And we've had to do that a couple of times, but part of our process is being able to identify those patients and have those relationships with them where we can really identify how they're doing and kind of, being aware of, the patient's, where the patient is kind of in that process and following it closely. And then how do we provide that care to the patient once they return to the hospital? We've actually built in a workflow where once they return to the hospital, they're actually met by the rapid response team at the hospital so they can receive whatever immediate care they need, whether that be intubation or CT scan or whatever they determine is the need for the patient at that time. And obviously those are things that can be done en route. Potentially things can be done en route if necessary, but we want to make sure that the patient is receiving that care in a timely manner, because in a brick and mortar hospital, if a patient declines, a lot of times they get that rapid response called on them where the team of caregivers arrives and kind of quickly assesses and determines a treatment plan to help prevent some type of rapid decline for the patient. And that's what we want to provide for our patients also. So these are our metrics basically from when we went live in January 31st to June 30th. So not the last month or so, but big number for our health system is that 1,220. That's the number of brick and mortar patient days that we've given back to the hospital by having patients in our program instead of clogging up hospital beds. So that's 1,220 extra days that they've been able to take care of a patient in the hospital, somebody that needed to be in the hospital because of the acuity of their care, because we've been able to take those patients, those other patients that were lower acuity, out of the hospital and take care of them at home. Right now, I said our capacity is 15. We have an average length of stay of about 5.5 days. We're taking most of our patients as transfers from the brick and mortar. We've only taken about 12% or so directly from the emergency department. Those numbers are a little bit better in July. It's up a little bit. Our goal is to get that up to 20 or 25% directly from the emergency department. And we're working on that, and it just takes time. We've ending in June 30th, we did 198 admissions. We're well up into close to 250 now, probably. But you'll see that our readmission rate is about 10.5%. So we really only had 20 readmissions of almost those 200 patients, which a normal readmission rate, especially for a patient population that's high in Medicare and Medicaid participants, is usually up above 20%, 20, 25%. So 10% readmissions is pretty good for that patient population. So our average daily census has grown, and we're sitting up around 10 now. That 9.14% is our patient return to the hospital data. So those are the amount of patients that we've had to return for some type of decline or escalation in care of the amount of patients that we've taken care of. So pretty good data overall. I'm happy with where our program is, and we're really just trying to build for the future, and excited about that restorative care program that's coming in January, because like I said, I really think that's where the rubber meets the road, and you get your bang for your buck as far as really preventing future problems and really utilizing the model and to its fullest. So happy to take any questions.
What's been your biggest hurdle?
So I think our biggest hurdle has been buy-in from physicians. So the big questions, like I talked about, that we get when we first present this model to people, like when we went to talk to ER physicians at Baptist, the big thing is, well, this doesn't sound safe. I want my patients in the hospital. It's we don't do telemetry with our program. It's another thing. If the patient needs continuous telemetry right now, it's not something we offer. And they're like, well, all of our patients that come in need telemetry, or we wouldn't put them in the hospital. If they're not sick enough to need to be in the hospital, we wouldn't put them in the hospital. And so just kind of presenting it and presenting the information, enough that people can kind of wrap their heads around it, and kind of understand kind of what we're doing for those patients. And we get the same pushback from, hospitalist attendings. They say, oh, I don't, maybe they'll be ready, oh, now that they're about ready for discharge, maybe we can look at the hospital at home program. And a lot of people view us as kind of a discharge substitution option. Like, oh, they're kind of ready for discharge. This hospital at home is kind of like home health, so they can probably do that. And really, we want to get those patients earlier, right? We want to get them out of the hospital, let you put a sicker patient in the hospital, and let us provide that care for them at home and transition them back into home in a safe manner. So I think that really just provider buy-in has probably been, one of our bigger hurdles, and we're doing better at that, but it's just kind of a thing where we continually build those relationships and continue to go back to their department meetings and meet with them in person, just kind of talk to them about everything that's going on. Okay. Yeah. I mean, like I said, we do up to 6 or 7 liters of oxygen. I mean, we can do pretty much any antibiotic regimen. We've done patients, like I said, with TPN before, who are NPO and not able to eat. We've done continuous dose IV Zosyn. So I think that, we can do a lot of, pretty complex stuff from that standpoint. I think that just because they need something pretty frequently doesn't mean that we can't necessarily do it. So I think, we're open to, a lot of different options for, taking care of our patients. So. Yeah. No, we had a lot of support from our legal group from that standpoint. We haven't had any issues. And really, I think the issues overall around the country are pretty minimal, for hospital home type programs. We really put a lot of effort into kind of trying to ensure that safety. And we have, pretty intensive weekly safety meetings reviewing really anything that happens with our patients. And at least the results that we've seen have been good, from that standpoint. 30 miles, really. So, we've taken care of patients. McLeod is one of the further ones that we've done. I think we had one person that was up near Okarche. And most of the patients are here in the metro area, but sometimes people come in from a little bit further. Since going live in Edmond, the Canadian Valley, that really stretched our radius further. So we're, almost up to Stillwater. If you go, 30 miles up past Edmond, and so, one of our goals is to, we're looking at expanding in 2023 into, and maybe depending on, where we're at, looking at going into Enid, the Enid area with Integris, the hospital there, and then also looking at the potential of expanding in the Miami and Grove areas with the Integris hospitals we have there also. So, the question is, does the program look different in those rural areas, and how do we incorporate it in those areas? Try to figure that out. But I think that's our goal, is to be able to move into those areas also.
All right, thank you. Okay, I think everybody can hear me fine now. So thank you for allowing me to give this lecture. It's been a little while because these updates, we'll get into them, where I came out, I believe, in 2017, 2018. And I was given this, initially then, and not much has changed, but that's good, I think, because, they're pretty solid recommendations from the American Heart Association, all the cardiology guidelines that came out. They've kind of stuck around since. So hypertension can seem a little boring sometimes, but I think there's some important things to pull out of this that hopefully you can use in practice, and kind of update your treatment of hypertension still, within the last few years here. So, before that, when these came out, we're always looking for the JNC 7 and 8 and things that came out in my training, which were, to sum it down, most indications were, treat people to be less than 140 over 90. And, if they kind of stayed elevated consistently over that, we would treat. And then that was like stage 1 over those levels, and stage 2 would get to like 160 over 100 and above that. And but there, and still we kind of use our discretion at extremes of age, especially elderly patients. They kind of lowered the raise the threshold to treat at higher levels to not get too low in older patients. But, kind of still at that time, they started narrowing down our first line treatments to thiazide diuretics, calcium channel blockers, and ACEs or ARBs. And, specifically looking at ethnicities, calcium channel blocker and thiazide diuretics for Black patients. ACEs and ARBs and more first line and Caucasian or white patients, but we don't have to worry too much about that. And, looking at certain populations with CKD, diabetes, things like that for specific antihypertensive agents, which we'll get a little bit more into as this goes on. So in 2017, these American College of Cardiology, American Heart Association, these have been the guidelines that have just kind of stuck since then. So they updated the terminology to sorry, it sounds kind of going in and out a little bit, but we'll get there. So no pre-hypertension, just elevated blood pressure, then stage 1 and stage 2. So that's kind of where we sit instead of worrying about pre-hypertension and this and that. Overall, there were more stringent thresholds or a lower level to treat patients initially and for goal treatments, but really mainly in those that are higher risk. And I think hopefully we can simplify some of this because there's more risk factor stratification when we think about what we use, is that ASCVD risk score. And that's coming into play a little bit more now is like, what's your 10-year cardiac risk score? We look at that for hyperlipidemia treatment, but they want us to put this into hypertension treatment too. But I'll try to simplify that, but because it's still not everybody we treat lower, it's the higher risk patients we initially treat at lower level thresholds. So again, there's their inclusion of the ASCVD risk score. And they really try to focus on non-pharmacologic treatments that, most of us, of course, we get busy, we're in the office and, here's your ACE, here's your, amlodipine, whatever. And they really want us to try to push non-pharmacologic treatments because certain ones can definitely have a significant effect on blood pressure. So I will say, the lecture, it moves along. This bounces back and forth on topic a little bit, how it's laid out. This is how it was laid out in the guidelines, so I kind of followed it. I know I probably could make this a little bit more flow a little easier, but they start with measurement. So I think most of us kind of know that a patient is supposed to be sitting in a chair, generally with your back supported, your arm that you're checking at heart level, hopefully resting in a quiet room for 5 minutes, but hardly any of us, we march them in, we set them down, and we check their blood pressure. That's just kind of how it goes. Let's see here, and I think these are just some fine points about correct size cuff. Of course, too small, too big, we can get incorrect readings. Greater than 2 readings, usually, we'll usually repeat if it's elevated. Just practically, what do we do in the office? We sit them down, we check automatic, and then we'll repeat again if we notice it's elevated. If there's significant elevation, usually we make sure it's done correctly, and they do recommend manual blood pressures for more accurate, readings. But usually you want to check it, even if it's elevated on a separate visit as well. Usually they say by the 3rd visit now, even more than just 2, but we won't get hung up on that too much because what we'll get at here is eventually about home readings and things like that. So again, just to harp on the fact that they really want you to focus these guidelines on risk factor stratification. And that means really talking to them about their smoking, which can, are modifiable risk factors. So smoking, treating diabetes. Now we have, I think this will come into play more, but we have diabetes drugs which lower blood pressure, like the SGLT2 inhibitors. So maybe that will come in here somewhere on updated guidelines. Again, weight loss, which is probably the most effective area we can lower blood pressure. There's the DASH diet, salt reduction, and sodium. But weight loss is probably the most impact of lowering in systolic blood pressure. Exercise, physical activity, diet, but some things we can't do a lot about, on the other side. Already present CKD, we can try to slow the progression, age, socioeconomic status, male sex, obstructive sleep apnea, we can treat it, but we're just not sure how strongly that affects blood pressure. And stress in general. So hopefully we can do something with that, but again, it's hard to completely improve. So the new categories that I mentioned, again, let's just say there's these tables and ranges, and I don't want to confuse anybody, but less than 120/80 is considered normal in these guidelines now, which is, lower than what we used to think of. We're like, you stay over less than 140/90, you're good, But what should be normal is less than 120/80, naturally. And then we think about that area where we got to start looking, which is elevated, which is just, over 120 systolic, because usually we're catching elevated systolic blood pressures. But where stage 1 and 2 starts now, instead of that 140/90, is over 130 systolic or over 80 diastolic. And that's what they're going to call stage 1 if it's sustained on separate visits elevated above those levels. Then stage 2, more advanced stages of hypertension is now what we used to call the first stage, which was greater than 140/90. And, you know, those are really the things we're looking at to say, are we going to treat or not? You know, those two areas right there. In the end, home readings are really important. We know that blood pressure is probably a little more elevated in the office than it is out in the world and at home. We also know how difficult it is to get ambulatory blood pressure monitoring and get that approved by insurance. Some payer sources, you can get it better than others, but I've just never gotten it done that effectively and at least on a wide scale. So home readings, of course, we want to use the arm cuff generally instead of the wrist cuff, but they're more reliable than in-office readings. And there is research that shows that if it's, you might have them bring their cuff in to the office to kind of calibrate or, you know, do with the manual if you're unsure if you got really a big discrepancy in readings between office and home. But again, you know, ambulatory blood pressure monitoring where they wear that 24-hour device and, you know, there's a lot of costs and just kind of hoops to jump through to get that set up. Again, you know, just kind of pushing the point on appropriate cuffs to use and just how important that home devices are and monitoring of blood pressure. So it says, you know, when do we check? You know, well, you know, usually what I tell them is give me a couple readings a day. You can do it in the morning before your meds and in the evening, but really I just want them to do it when they've been sitting down for a little bit, you know, 10 or 15 minutes and resting and relax, then take that blood pressure. White coat hypertension, it's a real thing. And unfortunately, it really infers that you will have higher risks of developing, you know, cardiovascular complications and events. You're at higher risk for having white coat hypertension, even though you go home and your blood pressure is a little bit better. There again, to help kind of tease out if you're truly elevated, more ambulatory blood pressure monitoring, but really just home levels will help be a better predictor of cardiovascular disease due to hypertension when they're checking at home and what those levels are at home. Slightly increased cardiovascular disease risk, like I said. If you're having difficulty just seeing, man, what is their blood pressure? Is it high here? Is it high at home? Is there, you know, again, that ambulatory blood pressure monitoring can be useful, obviously, in a real strong diagnosis of hypertension. Okay, so anytime you diagnose hypertension, you have to, you know, decide, does this seem like your typical primary essential hypertension, or does it seem like a potential secondary cause? Like, this is odd. Why is this person hypertensive? This seems out of the ordinary. And there's just certain characteristics you want to think about for like to go down that whole rabbit hole of trying to diagnose this, which can be difficult and hard to figure out and sometimes not very fruitful, or you don't get real far. But just some things to think about are, of course, you know, you're on 3 or more meds and you can't even get the blood pressure down at all, you know, so that's definitely in resistant levels is 3 or more medications. And usually you want to make sure that there's a diuretic included in that combination. Abrupt onset, you know, hey, I've been having a perfect blood pressure for 5 years coming to see you, and now I'm, you know, 170 over 100 and we can't get it down, or it just jumps up that high. The younger the age of onset, you know, less than 30, you know, similar to things I'm saying, obviously very high malignant with end organ damage and things like that, that previously you noticed that they were fine. Significant diastolic hypertension and electrolyte abnormalities, but for sure, but that ties in more with, I believe, hyperaldosteronism and just significant, usually it's potassium related, you know, unless there's other really significant adrenal issues going on. So if you have some of those things, there are, you know, you should screen for that and look into working up a secondary disorder. That's kind of what it's getting at. So what are the most common secondary disorders? Usually renal disorders are going to be higher up on the differential, and that's mainly, renal vascular disease, and usually you're an older patient too. Of course, you can get fibromuscular dysplasia and some of these other things, but it's usually an older patient with renovascular hypertension. Sleep apnea, we can kind of maybe tease that out by patient profile and just questioning. But primary aldosteronism is going to be your main, other secondary potential area to look at, where you'll have these electrolyte disorders and things like that. Some of them are just, when we see, sometimes we're dealing with inpatient versus outpatient, but, drug use or any other substance use is very common to cause hypertension. FEO, we're all looking for a FEO because we studied it, we look at it, but very rarely will we get it, but it happens. We've all probably come across it once. And then, much more rarely, your thyroid disorders, usually much younger patients, aortic coarctation. Again, very rare hyperparathyroidism, which are calcium. You're going to notice that if you get a CMP, that's going to be pretty high. Usually, congenital adrenal hyperplasia is usually much younger patients. Again, some growth hormone disorders, and you will likely see those features. And, just thinking through some of those things, what's going to be more common that you're going to see is renovascular disorders, maybe hyperaldosteronism, some sleep apnea, and substance use, or even alcohol use too, affecting blood pressure. So again, just, to differentiate here, primary gradual increase in blood pressure over time. And that patient kind of fits it a lot of times. You're going to have obesity, you're going to have diabetes, you're going to have, sedentary lifestyle, things like this, and in a family history of hypertension. Secondary, much more extreme, usually in presentation, more systemic symptoms likely, will not fit that typical obese sedentary type patient. And so on some of these issues that we've talked about. Let's see here. Okay, and this goes on to other substances that can affect blood pressure. So, of course, we talked about alcohol, substances, especially the more sympathomimetic, amphetamines, things like that we see. It's just unfortunately common, is meth use and things like that. Of course, antipsychotics, you got to think about that on the patient on Seroquel and, Abilify and all these things. And, that's probably affecting, metabolic parameters, and eventually with weight increase, blood pressure too. Where I think about caffeine and things, and we'll get to this with some of the pediatric stuff at the end, but just even young patients, just the extreme, concentrated caffeine and energy drinks that you see now can definitely have some effect on blood pressure. And people get into a lot of these weight loss supplements and energy supplements. So you kind of have to ask, usually, if you're just kind of scratching your head, why something, a person's blood pressure is elevated you wouldn't think would be, or why you can't control it. Again, oral contraceptives in a young patient, or it doesn't have to be young, just those on oral contraceptives can affect that. Significant anti-inflammatory use, again, more substance abuse, long-term steroid use, I guess even short-term for sure, but hopefully you would maybe know that they were on that, but for sure long-term. And some rare, immunologic drugs or DMARDs or things like that. And that's not even in some of those in that categories that you would use for different autoimmune diseases or other things now. Okay, so kind of getting back of just thinking what can all affect blood pressure, what can all cause hypertension, or do you need to just be thinking about that you may need to counsel patients on? Now back to, there's a big push in the guidelines. I say new in 2017, 2018, but they still stand so far, is non-pharmacologic treatments. They talk about that, they say that heading, but what is it? So the best proven interventions are overall weight loss, hands down, can cause the most significant decrease in blood pressure. Just kind of like the mechanism is not the same, but just like diabetes, weight loss is going to be the most, bang for your buck there. So DASH diet, increasing fresh fruits and vegetables, and they're not, of course, they think probably sodium. Decreasing sodium is very significant, but also increase in potassium probably helps as well with blood pressure lowering. There's also some interesting data coming out about salt substitutes, and they do the potassium chloride instead of sodium, and that seems to have a significant they've noticed some sort of significant reduction in cardiovascular events when people truly substitute salt substitutes instead of regular salt. So that's something that's been being studied right now and having some good positive data coming out of it. Again, I said sodium restriction, physical activity important, and moderation of alcohol intake. So really just counseling on, especially if there's alcohol overuse. Sometimes it's hard to get people to stop drinking, but to cut back is important, So again, and this is a chart that they list that just shows, okay, well, what's the degree of lowering you can get? Well, even, with weight loss, getting up to, 5 millimeters of mercury or more of decrease in blood pressure is really significant, and that's for so much body weight loss. But DASH diet's really significant lowering, reduced sodium intake, and some of these will be additive, but only to a certain degree. But again, all these are very important, and if you can get somebody, to lower maybe 10 millimeters of mercury, it can be very significant to decrease cardiovascular future events and risk with that. Even weight training, isometric resistance, decreasing alcohol intake. We know those things are very important. So always counsel the non-pharmacologic, or just try to throw something in there, increase fresh fruits and vegetables. Maybe come back and we talk about weight loss or ways, eventually maybe pharmacologic, down the road, but just how do we need to, a lot of times I send people to nutrition because they just have no, they have never been taught, what can I substitute? What can I go to the store and pick out that I could actually afford that might work and be healthier? And I think it's important because, we're all so busy in the office. You need to use your resources to get, help for people. So what's the general workup we can do for, this is generally new onset hypertension or looking at it, but what is the utility of a workup and why do we do it? So, all these labs, the beginning labs are totally useful in looking at hypertension, especially to look at any secondary causes. So you look at a BMP at least, and you want to see if they have what their GFR is. You want to know that you want to be careful of the agents used based on what kidney function is. Well, what are their electrolytes? If their potassium's already 3.1, you want to be careful with throwing a diuretic onto that patient. So you want to know, looking at lipid panel, that's obviously risk stratification important if they have significantly elevated lipids. CBC sometimes is just looking at, already, maybe if there's any systemic diseases or significantly elevated white count, but sometimes a lot of times we'll catch it when we see that, really significant elevated H&H, and it's like maybe this patient has sleep apnea and they've got a secondary polycythemia due to that. But really, I'm just saying you can see some things that other disease processes may be going on affecting the blood pressure too. UA should be covered, really just looking for proteinuria or hematuria as well. When it's a new onset hypertension and hematuria would maybe signal, obviously some kind of renal disease or I can't say, what I'm trying to say, glomerular disease and things like that. So, but really we're looking for proteinuria more than anything. EKG, that's just looking for any, a quick screen for cardiac abnormalities. And then the other things that I'm getting at is, echo or more advanced testing or specific, it's optional. You may not jump to that at first anyways, but The echoes come in a little bit more like for new diagnosis of hypertension and how important that may be sometimes in the pediatric world, which we'll touch on. So treatment, let's get to treatment and thinking about treatment. We know, and then I'll jump back to in a minute again, like who to treat at what level. Okay, so use medication for secondary prevention. So this is getting at like who are we going to treat at that lower threshold of 130/80 and trying to get them below that. Clinical evidence of cardiovascular disease. So kind of thinking about it, it's like people with statins too, if you've got underlying, coronary, vascular disease, or you've had stents, or you've had a heart attack, well, we're going to treat you with a statin, no questions. We're going to make sure your blood pressure is less than 130/80. We're trying to get to that lower threshold, no question. Initially, there's a lot to think about all the time, with a patient. So most people without then, okay, that makes it easy. If you've got underlying disease, okay, we're going to treat you. We're going to try to make sure that we get you under that threshold and get a lower set point to reduce your risk of a cardiovascular event, stroke, what have you. So what about if they don't have that? Again, that's where that ASCVD risk score comes in, and kind of like lipids now or hyperlipidemia, you're going to calculate that, put it into the computer or your little app or MD Calc, whatever. And if it's above 10%, you're going to treat them to that lower threshold. So we'll get at, kind of like, when would you not treat that? But really, you're basing it on risk here. If you have underlying disease, bam, you meet that where they want you to treat at lower thresholds. If you have elevated ASCVD risk score above 10%, that's an indication for treatment. So, it's kind of like old guidelines, which is nice. So what about everybody else? We're looking at the more higher risk patients here, those with underlying disease or elevated risk. Now, what about everybody else? Well, you generally don't treat until they're to stage 1 now again. So sustained elevated over 140/90. And me in my head, I get confused on those things sometimes. That makes it easier for me. So we're still following old guidelines on everybody else that doesn't have these other couple things here. And there's a couple other groups like diabetic patients and things that they've kind of followed these guidelines. But we'll get into it and just kind of reiterate these points again. You don't have to, some of these are all in the guidelines, these charts, and sometimes algorithms are good and sometimes they're confusing, too many boxes, too many lines, but it's pretty much following along what I said is, okay, elevated blood pressure, we're just going to reassess and watch and do non-pharmacologic treatments, okay? So you're over 120/80, we really need to watch your blood pressure and counsel you on the things to do to keep it under control. So you look at stage 1 hypertension now, remember over 130/80, and then calculate the 10-year ASCVD risk score. So it's greater than 10%. On more than 2 visits, you're going to treat them. If they don't have that, if their risk is much lower than that, or they're too young to even calculate it, sometimes if you're not 40 years or older, you can't calculate that score. That gets confusing with lipids too sometimes. But again, elevated risk patients are the ones we're going to treat to these lower thresholds. And once you get to stage 1, then it makes it easier. It's like 140/90, kind of like we've always done it. You stay elevated above those points, sustained, we're going to consider treating you, okay? If the non-pharmacologic treatments or the shared decision-making that we decide on doesn't work. Again, don't want to confuse. It's just tables reiterate with the classification of the guidelines and their, what we just talked about. Okay, let's think more about preferred medications, because I think there is something to take out of this. And I try to talk with this about residents more about why are you going to use this and how would you add these and in what manner? So again, we still talk about how thiazide diuretics, calcium channel blockers and ACEs and ARBs are first line. Now there are well, we'll go in order here. So thiazide diuretics, all the initial studies and, most, studies with the really strong information over the years were really, they used chlorthalidone as the thiazide diuretic. And most of us probably know that, but we use HCTZ because it's just like ubiquitous, it's in combinations with all of our medications. It's just easier, to prescribe. And but chlorthalidone actually has more proven cardiovascular disease reduction and more proven blood pressure lowering, and really because it's more potent. That thiazide-like diuretics like chlorthalidone and I think indapamide is the other one, which we don't use as much. But anyways, I'm trying to use those more. So when do I use chlorthalidone? I use it more in the patient that I've got on lisinopril, HCTZ, and a calcium channel blocker. I'm really just, I'm really certain they're taking it, and I'm just not getting real far with their blood pressure. I'll change it up and throw chlorthalidone in there because it's probably going to cause some more blood pressure lowering. And you'll see the cardiology guys kind of throw those in that, they've got to use the cool drugs and all that, or the cool named ones and all the newest stuff anyways, but that's an old one that has a lot of data behind it. Now, I'll talk about it. Let me see if I have it on my notes here. I think I'll get to some more fine points on chlorthalidone. Don't want to spend half the time on that, but calcium channel blockers, very effective, especially amlodipine dihydropyridine is the most preferred, and amlodipine is going to be the most common one to use. So you have to just be careful with those types of antihypertensive if advanced level stages of heart failure. Otherwise, remember with thiazide diuretics, they kind of lose some of their effectiveness at significantly decreased GFRs, especially less than 30. So that's when you got to think about loop diuretics and other things. But usually, hopefully, they're going to be probably see a nephrology too then. Okay, so again, those agents, we'll talk about them more. And potassium sparing diuretics are in the guidelines, but more resistant hypertension and things like that. Now, one point to know about most antihypertensives are usually that starting dose, let's say no more up to 20 of lisinopril, but even, by that, even amlodipine 5 milligrams or HCTZ 12.5 up to 25, usually the most blood pressure lowering you're going to get are those initial doses. That's going to be the most significant lowering you're going to get, because we usually see, oh, let's go to these high levels of HCTZ or, but I'll see, I've kind of been trying to counsel my residents, a lot of them have been doing doses of like 40 milligrams of lisinopril when they don't see like they're getting far. But I think it seems that you're probably going to have more success adding another agent before going to a significantly higher dose of one singular medication, because they're just less effective the higher doses you get. Unfortunately, it's just that initial dosage that's going to do the most for you. And usually things like there's some trials, all hat trial, accomplished trial, but they kind of back that information up by the dosage they had on the patient and the information and data they got from all those levels. So again, use first-line agents. Try not to use beta blockers too much or other alternative medications, but there are times to use them, which is you got to treat the comorbidities. So if it's a diabetic patient, you're going to use the ACE or ARB, totally understandable. You're going to go with that first. Sometimes if a patient, I probably have a couple things here, but there are certain reasons you may go with a beta blocker, patients with aortic disease, patients with certain levels of, heart failure. Sometimes certain patients just need, there is an indication for that medication. Let's see here, the timing of the medication, there's a few, trials that show this about sometimes taking medication in the evening can cause more significant blood pressure lowering or to be slightly more effective. And that's that's kind of related more cardiovascular risk reduction. I wouldn't get too, hung up on that, but that's more people those people that they call them non-dippers, their blood pressure, which normally circadian rhythms and everything, our blood pressure gets lower in the evening. And that's what we want to see our body do. And some people don't do that as effectively. But we also have to think, I keep talking about these more stringent blood pressure goals, kind of like diabetes has gotten in recent years, but you have to use your discretion. You have to use shared decision-making, because we know we have lots of patients, frail patients high fall risk, patients with dementia. You're going to be careful using these much lower, getting them on over 130, over 80 and treating less than that and getting that blood pressure down, because we could very potentially cause more falls, more potential adverse, complications by being real aggressive with blood pressure. So really, they reserve that right for you to use your own decision-making with the patient. But overall, you follow up, every 3 months or 6 months when you're getting closer to goal. Of course, if somebody's running 160 or 170 or higher, you're probably going to see them every month until you start figuring out something. But long story short, the goal of all of this is to treat less than 130 over 80 when you are treating. And why do they have this lower threshold? Well, there's just this vast array of evidence that shows that patients have better outcomes with lower blood pressure, especially, stroke and MI and most of those worse cardiac or types of events we worry about. That's what gets significantly improved when we treat blood pressure really well. Some of the evidence, our A1C is less than 6.5, those micro and macrovascular outcomes aren't as impressive at even significantly lower treatment levels as they are when we relate this to blood pressure and things like that. This has a lot more evidence behind it to improve outcomes. Let's see here. So again, just thinking of specific scenarios. So ischemic heart disease, angina, that's why you may use a beta blocker sometime. Diabetes, proteinuria, CKD, ACEs or ARBs, aortic disease, beta blockers. Again, thinking about patient profiles, ethnicity, generally calcium channel blockers and thiazide diuretics are more preferred, likely more effective in Black adults. Thinking about not using ACEs or ARBs in young females that may have hypertension, especially if they're childbearing age or want to have children. And let's see here. Yeah, and just when patients are a lot older, you kind of have to have that shared decision making. Maybe you don't want to treat to that real stringent goal. That kind of gets through the initial stages here of adult medicine and what a lot of us probably do, but many of us that do family medicine also see kids, cradle to grave type of thing. So, and we are faced with pediatric hypertension, pediatric, metabolic disease much more frequently now. We have clinics up at OSU that we work out in East Tulsa, some of them high Hispanic population, and across the board, a lot of obesity, but we really see it, especially in, lower socioeconomic status and Hispanic population for sure, just in that specific clinic we have, and we're faced with this a lot. So the main thing I think anybody should take out of this talks about some treatment, this talks about workup. I think the most important thing more than anything, and I tell our residents this, is diagnosing, is recognizing pediatric hypertension. Over 75% of pediatric elevated blood pressure hypertension goes unrecognized or not diagnosed because, it's elevated, we'll check it out, or you just don't see it or you don't think about it because it's percentiles. It's different in the way you think about it. And we're just not real familiar with treating it. It's kind of a newer phenomenon, and unfortunately not a great phenomenon, but something we're faced with. So again, like I said, higher rates in Hispanic and African-American children, and higher blood pressure as a child really means usually that you're going to have higher blood pressure as an adult as well. So there's some screening tables here. Again, it's based on children with a normal weight, and age and height is the way you look at it. But, you know, most of ours, thankfully, in EMRs, they'll just say, hey, it's this percentile for you. You know, some of us still are on paper or other things. And I used to love paper too, but it will do a lot of this work for you. So you can just recognize, you know, or do they have elevated blood pressure? So again, these tables just help us identify, you know, who needs to be, you know, watched, who is out of range here and we need to keep an eye on. What's nice is, well, now they recognize that when you're 13, really hit those adolescent years. Once you're 13 and older, you just go by the 130/80. That's so that you don't have to worry about percentiles once you get 13 years old. But for the littles, you know, you got to go by the percentiles. Again, tables arranged by age, gender, and height. And we should really be looking at blood pressure by age 3 and on, you know, for sure 3 to 4 years of age. Again, just proper measurement, you know, kids, it's all the time. And I think we all see it where they come in and their blood pressure is kind of elevated. And I just got to tell them, okay, recheck it, make sure they sit down, see if they've calmed down just a little bit. And 9 times out of 10, I get a more normal level when I recheck on a pediatric patient. And this shows kind of measuring from the acromion down to the olecranon processes and the length of the cuff, and just, you know, appropriately checking their blood pressure and the process of that. I believe this is just talking about the measurement. What I'll get into is what percentile. Okay, let's try to make this a little easier too again. And what percentile am I looking at that I need to start, you know, using some discretion and worrying about a little bit. And it's really over 90th percentile that you'll start thinking about this. And then you'll repeat, hopefully manually, and then for the most accurate reading, and kind of go from there and see if it's elevated at subsequent visits. So with the pediatric patients, the normal blood pressure, when you're looking at percentiles and they're less than 13, is less than 90th percentile. So it's elevated when you get over the 90th percentile. And then the next number is 95 and above. So again, looking at these percentiles, and really when you're over 90th, then I'm kind of like, okay, all right, I got to look at this. And then they're over 95th, then you start saying, okay, I think I have to do something about this or watch this closer when it's 95th and above. That's the way I think about it, you know. They really push, and I think everybody is. This is based, you know, these recommendations are the American Academy of Pediatrics too. And they kind of followed, you know, and worked with the ACA and AHA and all that to kind of come up with this. But close follow-up every 3 to 6 months when you're elevated, and then non-pharmacologic interventions. And we'll kind of talk about that. So stage 1, okay, greater than 95th percentile, you're going to watch them closely. You're going to follow up, you know, maybe see them in a month, and then, you know, make sure if it's still elevated, then go from there. But if a child is ever symptomatic, really my education here is they probably need to go to the ER. If I've got severe headache, you know, I'm passing out, shortness of breath, significant elevated blood pressure over the 95th percentile with symptoms, they should be seen by, you know, inpatient, and likely seen by pediatric cardiology or somebody, or just make sure quickly that there's no signs of end organ damage and kind of go from there. In kids, you know, sustained elevated blood pressure in any of these cases, if it continues and you follow it up, you're usually going to check for coarctation. So you're going to check an upper extremity and a lower extremity blood pressure, see if there's significant discrepancy between the two there. Stage 2. And that just means, like I said, this still confuses me sometimes, but usually when I see somebody that's 98th to 99th percentile or higher, that's bad, you know, and that's going to be closer to stage 2. But there's this range of stage 1 is 95th percentile to plus 12 millimeters of mercury above that. And then stage 2 is above that. And I try not to focus a lot on this because it gets confusing sometimes. And really, I think that if you see somebody who has significantly elevated blood pressure, and I'm talking about 99th percentile or higher, or they're around that 95th and symptomatic, these are bad things, and this kid needs to get checked out quick, and you need to recheck that blood pressure and make sure quickly, within a short amount of time that it does not stay sustained, especially if they're even if they're asymptomatic. If they're symptomatic, that's more of an emergent treatment. Adolescents, again, we're just looking at the regular 130/80 by age 13. If they're getting into these levels that are 170, 180, that's an emergent treatment for a child too. So this is just like, what are the red flags here? Really extremes, again, when you're over 13 or 98th, 99th percentile in a young child that stays sustained or with symptoms. Again, just reiterating the stages that I discussed, not trying to harp on that too much, but just know if you're over 90th percentile, I want to say, what's going on here? I better check this. Over 95th, we really have to start getting, I guess, worried a little bit more. Again, these days they keep talking about instead of 2 separate visits, 3, but generally by 2 separate visits, if you have sustained, and by that 3rd, you can diagnose the hypertension if it's 95th or higher. Again, greater than 130/80 in an adolescent. Like I said, they even admit these blood pressure tables can be confusing, and looking at percentiles. There are more simplified tables just to look at 90th percentile and go from there and recognize, I got to watch this kid. I've got to follow up with him and make sure this isn't something that keeps continuing. And here's one of these tables in their AAP guidelines. You can look up like pediatric hypertension guidelines. And again, there's table after table. And this is just more of a screening thing if you want to put that up and tape that up in your office or keep it somewhere for age and height, and differentiates as it does. There's a difference between boys and girls on blood pressure. So how do we put this together and make sense of it? So you're really just identifying those that you need to monitor and schedule follow-up and watch. That's the main thing I try to tell our residents is like, you don't have to know all these percentiles, but you just need to know a couple set points to not miss it and recognize it so we can do something about it and they're not on dialysis when they're 25, identify, comorbidities of eventually, obesity and diabetes or hyperlipidemia. Give the non-pharmacologic counseling. It's slightly different for kids, whereas just like activity is going to be a lot more of your counseling because most kids it's inactivity. Even if they're overweight, they need lots more activity than adults. And start treatment if indicated. And we have to do this which is unfortunate, but I think usually a useful maybe part to this lecture is our residents always is like, well, okay, when the kid has elevated blood pressure and it keeps going, well, what do I do about it? How do I work it up? Well, if the kid is 12 years old and his BMI is greater than 99th percentile and he has a poor diet and he's sedentary, it's much less likely that that's secondary, it kind of fits. But we think of, again, profiles are usually older than 6, family history, overweight and obese, and it's going to be more primary. Where secondary is, I've had it. The young, thin kid who comes in has got significantly elevated blood pressure, no family history. It was normal. His last well-child check, now it's significantly elevated. UA abnormalities, and just the severity of the hypertension. So, I've had a kid before where very thin, tall, young kid, and, blood pressure is 140/90. I recheck it, it's at, see him in a month, it's, 150/. Anyways, get some lab. I don't even know these guidelines then. And he, I think his renal function was slightly elevated. And I got an ultrasound of his kidneys. Anyways, they find this huge renal mass. And the kid ended up being okay. He was treated, and I think it started as a primary testicular cancer that turned into a retroperitoneal mass. But thankfully, things turned out okay. But so how do we sift through this, and what do we look at? Well, we'll kind of talk about my general workup and what they recommend, more than what I do. So renal disease is the most common secondary. So kids with those, they had all these renal issues or urinary issues where they had frequent UTIs or they have congenital urologic or kidney issues. That's going to be the most common secondary. There's some history of renal or urologic disorder. Much more rarely, but can happen in aortic coarctation. That's why if you notice it's elevated, you follow up, it's still elevated, you'll check upper and lower extremity blood pressures. And just sometimes things like, kids on steroids, stimulants, which we'll see, may ask about decongestant use those times of years where allergies or change in seasons are bad, a young female on oral contraceptives, things like that. Let's see here. So they still recommend, as part of this workup, doing risk factor stratification. And we'll talk about how we do that. But a lot of times, these kids, not only are they overweight, but a big thing now, again, energy drinks. It used to be, I used to say it was Flamin' Hot Cheetos and Mountain Dew. That was the thing, like 5 years ago. Now it's Takis and energy drinks, and they all do it, it's just popular to eat these extremely high sodium snacks and drinks packed with caffeine. So ask them if they're doing those things and if you can change that. Okay, let's kind of fast forward to what kind of workup do I do? So what lab do you do? Always do a UA, because you're looking for proteinuria or hematuria or any abnormality on a UA in a kid, because more so urological renal issues will be at play if it's secondary. Definitely a basic metabolic profile, looking at electrolytes and renal function. For most, especially if they're overweight at all, we're going to do a lipid panel. That's just the risk factor stratification. Obese, we're going to get an A1C. Those LFTs will come if you get a CMP and lipids. And you can do some of these others. If you suspect something like some substance use, you can get a UDS. You'll usually get a thyroid in there too. But let's just say, what do I usually do? I usually get at least a CMP, a UA, lipid panel. I won't always get the A1C if they're not overweight. I'll consider it. And I usually do get a TSH to make sure thyroid disease isn't at play. I'll get a CBC just to see if anything is off for any other systemic diseases. Anything like that. So imaging, I used to always say, get a renal ultrasound all the time, no matter what. It's really most useful if they're much younger patient. Less than 6 is really what they recommend, or you have abnormalities on your UA. I'm not going to fault you for getting a renal ultrasound and looking that way, but that's much more higher utility when they're much younger and younger than 6, or their UA is abnormal at all, or they have any significant, obviously, renal decreased GFR, something on your UA to look for obstruction or anything, going on. Adults, we don't always order an echo, but if a child has sustained elevated blood pressure, we order pediatric echoes. And why we do that, I always have to put my note, but you get your echo for assessing left ventricular hypertrophy, because that's the most prominent manifestation of end organ damage in a child if they have LVH or any cardiac, wall abnormalities on that echo. And that will tell you right away, you've got to get this child treatment, because it's going to work significantly worse outcomes if you don't, and they've already got LVH on their echocardiogram. If there's snoring or sleep issues, you can get a sleep study, and that's recommended. But again, UA, CBC, CMP, TSH, I'll get a lipid panel. And then if they're young, I definitely get the renal ultrasound. And if I'm working it up in 2 or 3 visits, they have elevated blood pressure, I'm getting a pediatric echocardiogram. I just have to put it that way as the order, because I have to go to pediatric cardiology to get that read, or that's who reads that echo in our area. And I'm sure, most any area. So action plan, is seeing if I wrap that up. Yes. This is kind of for all of them, so, but still physical activity and increasing fresh fruits and vegetables, really just trying to get them to cut out those sugary drinks, those, poor, empty calories, and energy drinks and all these things and increase activity. That's my first thing I say to kids, because it's hard to get kids to lose weight, but hopefully you can slow their weight gain over time as they age. And then they'll kind of, as their height goes up, they'll grow into it a little bit. Because like I said, weight loss is just hard in a kid. It's hard to get them to lose weight, but if we can just, get that maintenance to slow that weight gain, it can be significantly important. Let's see here. It said, update recommendation in 2022 likely. I don't know if that's going to happen. They said that a couple of years ago, but we'll see. But most effective intervention in kids is usually making sure they get like 30 to 60 minutes and hopefully 60 minutes of activity a day. Whereas a lot of times we'll say at least 30 minutes an adult, but again, kids just need more activity. So if we can get them to try to change the options they may choose in their diet and increase their activity, we can make some sort of a difference. Can't remember next okay, good. Pharmacologic treatment. Not a lot on this, but sustained hypertensive children in that stage 1 to stage 2 for sure. We still use the same agents mostly as adults. They're still first line. If they're symptomatic hypertensive, I'm probably sending them to the ER. But stage 1 to 2 that stay sustained, 3-6 months or more, usually 6 months or more. And then stage 2 for sure, just significantly elevated blood pressure. We're going to have to treat, and I've had several children I've treated and continue to treat, but usually I'll make sure they don't have something. Yeah, there we go. So who do we treat? I said not elevated blood pressure, just like adults, we're going to do non-pharmacologic. Stage 1, you're going to do all the lifestyle changes and you treat if they keep staying elevated after 6 months. If you look at their labs and they've got some renal dysfunction or some things off, or their echo shows LVH, you're going to have to treat that kid if they're not getting that blood pressure down with lifestyle changes. And stage 2, like most, they say treat right away, And I try not to get hung up on everybody knowing, even the residents, like, oh, which one of these stages and when do I treat? Because usually you're going to be following them. You're going to see them over time. And over 3 to 6 months, you want to make a dent in that with something. And if you don't, you're going to have to think about treating them, unless it's really advanced stages of that stage 2 or higher, or you see end organ damage. Okay, so preferred medications. Generally, I don't do diuretics in kids because, they don't want to be going to the bathroom more or anything like that. So I don't do diuretics much. But you can if you need to. But it's generally going to be a low dose of amlodipine or a low dose of an ACE or an ARB. And by that, I mean starting at 2.5 of amlodipine. If it's a big kid, a 14, 15-year-old, 200 pounds or more, you can probably start at 5. But there's no problem starting low and working your way up slowly, or starting, let's say lisinopril, 2.5, 5 milligrams, losartan, 25 milligrams, starting at about the lower doses that you think about on that, and then watching it and watching it slowly. Again, beta blockers aren't first line, but you want to be careful with that, especially because, just athletes or kids that are trying to be more active and blunting that, heart rate response and things like that. Always thinking about sexually active young females and ACEs or ARBs, trying to avoid that. Now, I think we're getting close here. I wanted to see what's on this next. Yeah, you're going to be following up, every month at least, usually, or 4 to 6 weeks when you make these changes. And over time, within a few months, you want to see some improvement. And so hopefully by 3-6 months, you've made that improvement, and then you can kind of pull back or, extend those visits out, or they're making those lifestyle changes like we would want anybody to be, and we can start titrating down on these medications. That's kind of, just looking up, I think the workup is kind of nice to know for pediatric patients, but really also just the recognition. Over 90th percentile, I'm thinking about that 95th percentile set point and higher. And this is a lot of numbers and it gets a little boring, but I think just knowing the first line medications, adults and children, but especially with adults, knowing that the initial dosages are going to get the most blood pressure lowering, We'll see, there's also some good trials going on with poly pills where they'll give you this little pill and it's got like 4 medicines in it, but really low doses of like a beta blocker, an ACE, a diuretic, and a calcium channel blocker. And it's showing significant blood pressure lowering with very few side effects. And that kind of backs up the evidence that at beginning levels dosages get us our most blood pressure lowering, but really trying not to get side effects too, and avoid that and keep people taking their medications and not taking multiple pills. So the poly pills are a real interesting concept that we're starting to see, but you can't order that or send it to the pharmacy, but I think one day we'll be able to. And one thing I usually tell, so when do I follow lab? And, I start somebody on this, what am I supposed to check? And I usually check if I'm doing an ACE or an ARB, or I'm doing diuretics, I'll usually check a follow-up BMP or something within 2 to 4 weeks. And why is that? It's just because usually that will uncover like some sort of secondary cause if you have significant drop in potassium or increase, significant response to a diuretic. And of course, with ACEs or ARBs, just to watch the potassium initially, because usually even with a diuretic, which really chlorthalidone, you have to watch this about because it works really well. It's just more potent. So you're going to know within the first 2 to 4 weeks whether you have significant, your potassium lowering or it's going to be real potent in that patient, because it takes just about 2 or 3 weeks to get that steady state level of that medication in your body. And then you don't have to check it as often moving forward. So a little bit about, monitoring hypertensive patients initially and when we start them, and those beginning dosages that are going to get your most lowering initially. So I should have put a recap here at the end, but again, we're only going to treat the most stringent in adults when their stage 1 and their 10-year cardiac risk score is greater than 10%, or they have underlying disease. Diabetes is this way too. They recommend treating less than 130 over 80. And by that, I mean AACE and American Diabetes Association, those guidelines. And otherwise than that, if you don't have any disease or anything, it's still that 140 over 90, which is now our stage 2, which kind of is the way it used to be. And again, just recognizing elevated blood pressure leading into potential pediatric hypertension is important, and referring, whether you refer to pediatric cardiology or your pediatric, counterparts or anything like that. I believe that is, the main take-home points from here. There's my family there, and this is probably a year ago, so we're already much older and wiser here, but than this one. But again, most of this is from the big guidelines from the ACC and AHA that they put out, and I really haven't seen a significant update recently. Up to date, I'll use up to date a little bit to look at some of the trials that are used and some other documents. So thank you very much. I don't think there were any questions or anything, so I don't know if we're looking for questions out here, but it's not the most exciting topic, but it's always important, I think. So, all right. Well, thank you.
Well, it's a pleasure to speak to you here today. And when I was told that they asked me to talk, that I could talk about anything that I wanted, and that the people that I'd be speaking to were diverse. So I was racking my brain about what to talk about. And I ultimately decided to pick random topics that I thought your patients would find interesting, because either some people know about them, but maybe aren't ordering tests or aren't putting the diagnosis on the chart. And I think this is going to make a big impact in your patients' lives. I am a speaker for Rhythm Pharmaceuticals. One of my topics is going to be about rare genetic disorders of obesity, and they do make a medication that treats these, but I won't be talking about the medication itself, so I don't feel like it's a conflict of interest. And we're going to be briefly reviewing pathophysiology and treatment of lipedema, genetic obesity, and Lp(a), and then kind of summarize why I think these are important. Our first topic is lipedema. How many people have seen a patient that looks similar to this in their practice or where they practice? Before we get into it, let's start with some terminology. So I think we all know what edema is, fluid in the interstitial space. And then we have lipedema, which is a chronic condition characterized by disproportionate adipose tissue in certain body parts. That definition is a European definition, and they say in women, but we know that it can be in men. So I prefer the US definition, which says it's a disease of loose connective tissue on the lower abdomen, hips, buttocks, limbs, sparing the trunk, hands, and feet. Lipohypertrophy is a little different. Some consider it a precursor to lipedema. Other people consider it a completely separate entity. But what makes lipohypertrophy and not lipedema is that it's painless. I would say most people I see in my practice do not have pain until they're more advanced in age. And then lipolymphedema is an advanced stage of lipedema, or stage 4, if you want to think of it that way. And it's associated with lymphedema as well. So Allen and Hines first described lipedema in the 1940s at the Mayo Clinic. And they're the ones that created the name. They believed that edema was a main feature of lipedema, and that's why it has it in its name. But we've since discovered that really when you use tools to look at the tissue, there may be some fluid changes, but it's really not a predominant feature of this disease. It kind of went away by the wayside. People forgot about it until the 1960s or 1970s. And there was a couple of case reports there. And then in 1980, there was another case report in a German journal. And after that, it started to gain more momentum and people started to diagnose it more and do more research on it. So what does this look like clinically? Lipedema is difficulty losing weight in certain parts of the body. Again, it is going to be in the hips, thighs, calves, buttock, upper arms. If it is in the torso, it's going to be the umbilicus and lower. It will not be the upper portion of the torso. Because there may be some vascular fragility, they may have easy bruising, and they might even report cool tissues when like touching the backs of their arms or something. It might be cooler than the rest of their arm. And even in the earliest stages, they'll have little rice nodules under the skin, which you might think of as gristle or something. But as it gets more advanced, it's large lipomatous areas. And they also may have some hyperflexibility. You can see in the picture on the right that those women are bending down, some of them with their hands flat on the ground. I certainly can't do that. And some women that you might not think are very flexible are actually very flexible, or they might be able to do things with their hands. And a lot of women, when I ask them, do you have increased flexibility? They kind of, smirk because they're surprised that I asked them, but they say, yes, I am very flexible. You'll also notice the cuffing at the wrists and the ankles. You can see it there in that picture on the left. It doesn't have to be at the ankle. It could just be at the knee. If it's the upper arm, it could be at the wrist, or it could be at the elbow there. And this commonly starts in puberty. We believe mostly after hormonal changes. So puberty is very common after they're put on birth control, childbirth or menopause even. I recently had a lady, hers started with menopause, but that's not very common. And there can also be loss of tissue elasticity, which you'll probably see mostly in the upper arm there. There are different stages, and the Europeans and the Americans, they kind of like diss each other in their papers if you're reading it, but basically this is the American staging guidelines. And stage 1 is described as subdermal pebbles or enlarged hypodermal subcutaneous adipose tissue. And so you may have an individual that has fibromyalgia when in reality they have lipedema, and they may have tender points. And when you're feeling the skin, you might be able to feel these areas as small little pebbles. Or they may just have lipohypertrophy where they have thickened skin. And then stage 2, you'll have indentations and dimpling, larger mounds of fat there, and the Achilles tendon will have a thickened sulci, and it'll be hard to pinch. And then the upper arms, you'll have more of the hanging, and then the wrists and the ankles, you'll have more of the cuffing. Stage 3 is when there are gross deformations. It's going to probably spill over past the knee, be quite obvious visually. And then stage 4, regardless of how advanced it looks with stage 2 or 3, means that it has lymphedema now as involvement. With the different types, there's stage 1, which is umbilicus to buttocks. Then there is type 2, which is umbilicus to knees, 3, umbilicus to ankles, and 4 are the arms. And then 5 are the lower legs. I can tell you, I do not see 5, which is just the knee to the ankle very often. So let's go over these pictures here. You can see in A is somebody with stage 1. You'd look at them and you'd think, I don't really see anything, but this person is probably describing pain. Maybe when you take their blood pressure, their arm hurts. They might describe a family history of somebody in their family that presents with lipedema, and they should have areas under the skin that you can palpate. With stage 2, you can see more of the dimpling of the skin is present, and it's a little difficult to see here, but her right wrist, you can start to see that cuffing present. And then E, the mounds of fat are kind of going over the knees there, and it's causing some deformity of her ankle with some pronation there. With G, you can see the loose connective tissue that is very elastic with the upper arms, and you can see that in H as well. And then I talked before about how parts of their arm may be cool. That's often associated with levator reticularis as well, which they can have. And then you can see in the next picture, which is I, that the ankle is thicker, and then the cuffing of J. But K and L, interestingly enough, does not have cuffing, but they start to have that pronation of the ankle because of the gait abnormalities. Maybe it's involving their knee. This again shows the staging. So type 1 is the umbilicus to the buttock. So I call that the Kim Kardashian booty to my patients, and they seem to like that. But type 2 is the umbilicus to the hips and the knees. And then 3 is going to be kind of all the way the whole leg. And then 4 is the arm. It could just be the whole arm or the elbow again to the shoulder. Type 5 isn't shown in the picture. One paper has reported that lipedema may be present in 1 in 72,000 people. Although I can tell you by far, most studies say that it's present in about 11% of women. And I would say that is very accurate based on the people presenting to my clinic to see me. But you'll see a huge range in the literature. It mostly affects women. And again, this usually starts in puberty when there's some kind of hormonal change going on. I will say though, men can have lipedema. I was working with a man, and he knew what I did, that I had an obesity medicine practice, and he was telling me how difficult it was to lose weight. And I noticed that he had an entire sleeve on his arm, and I thought maybe it was to cover up tattoos or something. And I said, is that a compression sleeve? And he said, yes. And then I started asking more questions, and sure enough, he met all the criteria for lipedema, and he had a strong family history of it. And I was able to tell him just, on the side that I think this is what you have, and this is why it's hard for you to lose weight. And it can be very empowering for patients to be told that. In men in particular, they believe it may be higher relative ratios of estrogen to testosterone, but they're not really sure. And patients with lipedema also can have concurrent obesity. So about 80 to 97% of patients with lipedema also have obesity, which makes doing studies on these patients very difficult. And when doing family history, some studies report by Busso, for example, said 16 to 64% I would probably say 3/4 of my patients admit to some family history. And it's not always, you know, just mother or sister. It could be grandmother, or it could be like a aunt. It could skip the father. So it could be the grandmother on the father's side, even though the father doesn't present with it. So some have said it's polygenic. Others have said that it's autosomal dominant with incomplete penetrance. In studies, they've used high-resolution ultrasounds, CAT scans, lymphoscintigraphy, indirect lymphography, MR lymphography, dynamic lymphoscintigraphy, fluorescence, microlymphography. Yes, I did practice saying those, but don't ask me what they are. I can't tell you, but this is what they're using in studies to try to divvy out, in case somebody was wondering, what makes lipedema tissue. They are using tools like this. And this shows you why it's so difficult to study this and to make this diagnosis. There's so much overlap between these fat accumulation disorders. You have lymphedema, and then right in the kind of middle there with several overlapping features is lipedema. What they believe may be the cause, and it's ever changing, but they think lipedema patients may have excess sodium-rich fluid, and then that fluid increases loose connective tissue, and fat is a loose connective tissue. It increases the compliance of the fat tissue, and that stimulates proteoglycan growth. And that sodium-rich fluid will get out of the fat cell and into the extracellular space, or in the interstitial space, and that will stimulate glycosaminoglycans as well to grow. And because the sodium is positively charged and these proteins are negatively charged, they strongly bind, and this recruits inflammatory markers and changes adipokines locally, and this forms a scar tissue or a gel or a matrix, if you want to think about that, in between the fat cells. So even if they lose weight, the lipedema, scar tissue, fibrotic tissue remains. So again, you have expanding adipose tissue with increased elasticity. You have shifting of this sodium-rich fluid that causes scar tissue, that promotes hypoxia to the area, that promotes inflammation, and it continues to get worse. They've seen in the tissue that you have different macrophages locally, and that they've also had increased biomarkers for oxidative stress. One study looked at different genes that are associated. They found 28 different genes. Some of these may be associated with progesterone and its ability to be broken down. And they also think that women that have decreased alpha estrogen receptors compared to beta may also have increased risk. So it's probably not any one type of picture. In fact, they think that there might be different phenotypes of lipedema, and they're still trying to work that out. For those of you that don't feel comfortable after I talk about this, making a clinical diagnosis, there is a formal way of diagnosing lipedema that these authors did, but it's pretty obvious for most people, especially in the advanced stages. And this just kind of shows you what the tissue might look like. You can see with the white arrows is the scar tissue, that fibrotic tissue I was talking about, where the fluid bound those glycosaminoglycans and proteoglycans and formed that scar tissue. And then in C is a trocar from liposuction that went through the fat tissue, and you can see intermingled is the fibrotic tissue there. One study that used lymphography and lymphoscintigraphy found that the lymphatic flow was intact. It was not impaired. There may have been sluggish flow, or there may have been microaneurysms of the lymph capillaries, but they didn't see that there was a lymph blockage. And as I mentioned before, I think I said 80 to 97% of people that have lipedema also have obesity. So we know that obesity itself can contribute to swelling of the tissues. And some of that may have to do with the subcutaneous fatty tissue that surrounds the lymphatic vessels, compressing on the vessels, and also promoting inflammation locally to the tissues. So it's hard to say if the lipolymphedema that's in the advanced stages is related to the obesity or to the lipedema. So to treat lipedema, it's a multifaceted approach. You want to recommend physio movement therapy, compression garments, maybe mental health for body image issues like dysmorphia, weight management, which we'll talk about here in a second, liposuction, and self-management like using special brushes, which I'll show you here. So for compression, we recommend flat knit compression hosiery every day. For prevention, and when I say prevention, I mean preventing the pain that can be associated with lipedema, it's recommended to have 10 to 20 millimeters of mercury, and then you would go up on that depending on the stage, because the flat knit is felt to compress less on the lymphatics versus the circular knit compression garments. Exercise is really important, 2 to 3 times a week. If you're going to go by most guidelines, it should probably be even more than that, but we know that that promotes blood flow, and then that decreases inflammation, which is believed to help, especially help the pain. And then there's something called manual lymphatic drainage. That's something you can go to a physical therapist that's trained in this, or a massage therapist even. And it's a special way of doing a massage that kind of milks the lymphatics, if you will. And in the picture on the top right, you can see she's using a brush, and they can do these manual lymphatic drainage techniques that they're taught to do. And they use these little wire brushes that use the right amount of pressure to kind of help move the lymph along. There's less of a focus now on the lymphatics as more research comes out about this, but it does, we don't think that it helps the progression, but we do think it helps with pain. So if somebody came to me and they said, you know, what do I do for this? If their BMI is greater than 35, the number one thing I'm going to recommend is bariatric surgery. We know that there can be a 33% reduction in leg volume just having surgery itself. And studies show that after the surgery, patients may need the manual lymphatic drainage. They may still need the compression garments to prevent recurrence of the pain, but a lot of them will have pain control if you are aggressive after the surgery doing these things. If considering liposuction, we want to document for the insurance companies that it's been present for at least a year, that the lipedema has caused considerable functional disabilities, like restricting gait, causing ankle issues maybe. If they have had bariatric surgery, then we want to say that they've been, you know, weight stable for at least a year, that they've been compliant with wearing their compression garments, doing their manual lymphatic drainage, and that they will continue to be compliant, that they're in a psychologically good state, and that their BMI now is less than 35. All right, so that's done with lipedema. On to the next topic. I'm going to talk about obesity, but not just obesity, specifically rare genetic disorders of obesity. So all of you are probably familiar with this already, but I'm just going to review it shortly. We have a gene mutation on one allele that's heterozygous. We have 2 different gene mutations on separate alleles in different loci, and that's a trans compound heterozygous mutation. We have 2 mutations of different loci on the same allele, and that's compound heterozygous cis. And then we have 2 gene mutations in the same loci on different alleles, and that's homozygous. And when it comes to genetic risk with obesity, we have people that are, for the most part, you know, within normal range for their age, until maybe, you know, 30s, 40s, and they put on a little weight. That's what we would call common obesity, and those tend to be from polygenic risk. But then these rare genetic disorders of obesity it's going to be either a heterozygous mutation that was dominant, a compound heterozygous mutation that likely is a trans mutation, or a homozygous mutation. And these rare genetic disorders, they are going to present much earlier, probably as early as age 4 into adolescence. And so, I see adult patients teasing that out is very difficult. So knowing, I'm like, do you know where you were on the growth chart? I haven't got a single person yet that can tell me where they were on the growth chart. So, and I usually say, do you have any pictures? Do you remember people making comments about your weight? Did your doctor make a comment? Did your parents make a comment? Did a school kid make fun of you? When's the earliest age? Because we want to look for earlier than 10, although as I mentioned that some of these don't start till adolescence. These are just some of the mutations that are being studied for these genetic disorders. I think there's less than 100 here, but I think they're now over 100 on which ones they're studying. The ones with red have a treatable medication that is FDA approved for these disorders. The one in green is being studied right now, and all the ones in black, they're still trying to gather data. Obesity worldwide is about 2 billion adults worldwide, and overweight is, and then obesity itself is 671 million people. And these rates have tripled since the 1970s, and they're still continuing to go up, although the rate of rise is slowing down, but they're still continuing to rise. And it's expected that by 2025, 1 billion adults will have obesity. And in the US currently, the rates are, as of 2017, are 41.9%. I think I've read by 2030, we believe that'll cross the 50% mark. And I think the overweight and obese category is going to be in the 80 percentile as well. So these are some of the rare genetic disorders listed, like POMC, leptin receptor deficiency. And this is just an estimate from one source showing what we think the frequency of these is. But we also think that they're a lot more common than we think because people aren't testing for them. When you have the UK database where you can pull information, there's a lot higher rates than what are reported in literature. For example, I have a POMC patient in my practice. It's supposed to be 100 to 500 individuals in the United States, and I have one. So it's probably more common than we think. There are a lot of different contributors to obesity. It could be antibiotic exposure before the age of 2, because our microbiome is still being established at that point. Could be emotional or mental health stress, endocrine disruptors that we're finding in plastics and certain things like that. And I know it sounds like a conspiracy theorist when I say that, but we're still learning about that. Energy density of foods and how easily available it is. Epigenetics, whether some mother, as she was carrying her infant, had obesity herself, that's going to contribute to the child's risk. Exercise, lack thereof. Food accessibility, do they have access to healthy foods, or is there access to unhealthy foods too easy? What are their habits, hobbies? Improving technology like the people movers or the scooters you see downtown. Just the fact that we're trying to find every way possible to decrease our movement and our activity as a society. Decrease leisure time, people that are becoming workaholics, media that's influencing us to eat this and eat that. Medical issues like Cushing disease, for example, sleep duration that's shortened or poor sleep quality, social pressures like a church event where we're going to go and eat as a celebration for something, socioeconomic status, or even work activity. So I included this slide because I think it's important that when a patient comes into your practice, you think that it might not just be willpower. There might be all these different factors that are contributing to their weight. And I'm sure you do. I'm not saying that you don't. but there are these factors contributing to their weight, and they may need help, and they may have one of these rare genetic disorders and not know even that they need to ask for them to be tested for it. Why is it important to figure it out? Well, we know that obesity in young adulthood is associated with a 64% higher risk of mortality later in life and an 89% higher cardiovascular disease-related death. We also know that obesity is associated with multiple other diseases. There is a poster presentation from Massachusetts General Hospital, and I think it might have been published since, but they found over 212 different medical diagnoses that are associated with obesity. Sure, some of those won't be cause and effect, but quite a bit. And there's such a psychological shame and stigma that the parents of some of these kids might deal with. They might have to lock up their cabinets or their refrigerators or set an alarm in the house so that their kid doesn't try to sneak out and get food. They might have their kid try to pull food off of somebody else's plate in a restaurant or something. A lot of these behaviors tend to go away as the child gets older. And then they kind of internalize that and think that this is normal. Like the way that I feel is normal. And so they don't know to ask for help. When diagnosing in adults, we want to look at a BMI greater than 40, but if you're going to look for obesity in children and those at the higher risk of having one of these mutations, you're probably going to look at the 120th percent of the 95th percentile, or going by BMI with a BMI of 35. That's according to the Obesity Medicine Association, which is my preferred criteria. But there are multiple societies and you can go by any one. The class 1 for children is going to be greater than the 95th percentile, and class 3 is greater than 140% of the 95th percentile. And for those that are 0 to less than 2 years of age, you can do weight for length or BMI. And if you're looking for BMI, you can look at the International Obesity Task Force there on the right, and it has different criteria there. So let's talk just about hyperphagia, because when you're wanting to screen for rare genetic disorders of obesity, you're going to look for age earlier than 10 to increase your likelihood of finding a true mutation. You're going to look for, so the age, the weight, meeting criteria for severe obesity, and the third will be hyperphagia. And so hyperphagia is different than just normal hunger. With occasional overeating, that's like we're at Thanksgiving and whoops, like I just accidentally ate too much. Darn, like I don't feel that bad about it. Hedonic overeating is maybe you're on the couch watching TV and you're like, I just ate dinner. I'm not starving, but some chips kind of sound good. That's the expectation of pleasure by eating that food. So that's hedonic overeating. Then you have binge eating, and that's eating within a short period of time, like a 2-hour window, which can be grazing within that window, or it can be all at once, but it's a short period of time, and they're eating more than their peers in the same amount of time. And they describe a sense of loss of control while they're eating. And a lot of times it's almost like this mental separation, like they eat, and then they realize what happened. Oh, and then the guilt comes in. So that's binge eating. And then hyperphagia is described as an insatiable physiologic hunger. And it's more of a preoccupation with food. When's my next meal going to be? Like children may get distressed if they don't know when their next meal is going to be. So this kind of paints that picture. We have a control on the left, and then we have Prader-Willi syndrome patients on the right. And the control, you can see that they're rating their hunger about a 6 out of 10. And they eat upwards of 400 calories before their hunger starts to come down, and it stays down. But then we have these patients with Prader-Willi syndrome, and they're rating their hunger at a 9. And they have to eat 1,200 calories before that hunger comes down, but it only stays down for about 20 minutes before it rapidly starts rising again. So this is true physiologic hunger. These rare genetic disorders are listed here on this table here, and you can see most have an early onset, and they all have hyperphagia. Some of them may be associated with short stature or increased stature like MC4. They may have endocrine abnormalities like hypogonadism or hypothyroidism as well. And I think the POMC one's kind of interesting because they can have fairer skin than their family members. So they could be a Black individual with lighter skin. They could be an individual where everybody in their family has dark hair, but they have red hair. Or you might look at the root of one of their hairs and it might be a little red at the root of the hair. And that's because it's pro-opiomelanocortin, so it's the precursor to making melanin. Here are some more, and you can again see that these are mostly early onset, but you have Smith-Magenis and you have 16p11.2 microdeletion, which are in adolescence. So this is really a range of when people begin to present with this. Again, growth and endocrine abnormalities, and some of them will be associated with other medical problems such as Bardet-Biedl syndrome, or even maybe some intellectual delay. So when looking at these RGDOs, the main pathway that we believe is the major player of how weight is regulated is the melanocortin-4 receptor pathway. And we have these neurons in our hypothalamus, the AGRP neuron for short, and the POMC neuron. And we have all these hormones that act on those two, but in this particular diagram, they're using leptin as an example. So leptin comes from fat cells and its job's to tell our brain how much body fat we have. So leptin crosses the blood-brain barrier. It acts in the hypothalamus on these two neurons. And if it stimulates the agouti-related peptide neuron, it will shut down further stimulation of the MC4 neuron. But if it stimulates the POMC neuron, it will activate that. So if it's activated, the MC4 neuron, it will decrease hunger, increase movement, and then that will decrease weight. And if you have any issue along this pathway, you have leptin deficiency, leptin receptor deficiency, PCSK1 deficiency, which is an enzyme that cleaves that peptide, or melanocortin-4 receptor deficiency, you can't activate those neurons, and that will cause increase in hunger, decrease in energy expenditure, and an increase in weight. So we'll just do a little case study here with a Bardet-Biedl patient. Bardet-Biedl, there are multiple genes involved, but the genes that make this protein traffic the leptin receptor to the neuronal surface. So if somebody has a deficiency in this or a mutation in one of these genes, the protein will be decreased, and the downstream effect will be that the MC4 neuron will not be activated. So that will increase intake and decrease movement and cause weight gain. This patient started gaining weight at the age of 5 years of age. When looking at his pediatric growth chart, he's greater than 2 times the upper limit of normal. Parents are fine. Nobody in his family presents similarly. Incidentally, you find out through his records that he had an extra digit on his left hand that was taken away when he was a young child. And later into the 20s, developed rod cone dystrophy with gradual vision loss, and also had diabetes, dyslipidemia, hypertension, kidney disease, and fatty liver. He was later diagnosed with a homozygous mutation of BBS1 and therefore diagnosed with Bardet-Biedl syndrome. But because it's a syndromal obesity, it can also be diagnosed with classical clinical characteristics, with the most familiar criteria being the Bill's criteria. And that's going to be 4 primary or 3 primary and 2 secondary features. So this kind of gives you an idea of what those common features would be. So maybe some visual issues, kidney issues, so on, so forth. The only FDA-approved drug to treat these is setmelanotide, and it's currently approved for homozygous POMC, PCSK1, and leptin receptor deficiency. But it's also approved for compound heterozygous BBS, or BBS that's diagnosed clinically. So BBS is probably going to be the easiest one to diagnosed in children because of the criteria. All right, so the third topic, we've covered, somebody that will affect women, something that will affect children. This will affect everybody. So try to spread it out a little bit. But this is lipoprotein A or Lp(a). Let me go back actually. So this ball of red is probably an LDL particle. And on the surface, you have an ApoB protein, which is the ribbon that's kind of wrapped around the surface there. And floating around is an ApoA that will covalently bind via a disulfide bond to the ApoB protein on the particle. And you can see that bond is around 4,9 there. And so the ApoA protein is labeled, its nomenclature is Kringle domain 4, type 1, type 2, type 3, and so on, all the way to Kringle domain 5. And so the disulfide bond is on Kringle 4 type 9, and Kringle 4 type 10, which is right next to it, is believed to be the portion of the protein that oxidizes fatty acids and is the reason why it's so bad and causes such big issues, basically. The Kringle 4 domain type 2 segment there is very variable in length. So when measuring this, we want to do a nanomolar per liter measurement because it's going to be more accurate and it takes into account the variability of that particular segment, but all the other segments are fixed in length. When talking about ApoB, which was on that last illustration, we know that we have these large fluffy chylomicrons with lots of triglycerides, and then we have these small dense HDL particles. And the particles we really care about are the ones that have ApoB on their surface because those are the ones that are going to bind to artery walls and deposit their cholesterol. And in this diagram here, that's the particles in red, which are the chylomicron remnants, VLDL, VLDL remnants, intermediate density lipoproteins, and LDL. So the ApoA can bind to any ApoB on any of these particles, but because LDL lipoproteins are 90 to 95% of circulating proteins in our blood, we primarily think of Lp(a) as an LDL with ApoA. High levels would be greater than 50 milligrams per deciliter. And again, we don't really like milligrams per deciliter because it doesn't take into account the flexibility of that one segment I mentioned. And if we were to equate that to nanomolar per liter, a high level would be 105 to 125. And this is present in 20% of the population. So if you have somebody who is optimized on their LDL cholesterol and they're still having strokes, they're still having heart attacks, they're having peripheral arterial disease that's advancing, they probably have Lp(a) elevation, and that's probably what's driving their risk. It's highest in the Black population, and we know that it begins to be expressed starting around 2, and then by age 5, it's fully expressed. So if you want to know what their risk is for life, you have a family member like an adult that you know has it, you can check their child starting at age 5. But you'll have some people that will be, maybe 600 nanomolar per liter, and that's a huge risk, but they don't have any disease and you can't really figure out why. And they're thinking that maybe there are certain phenotypes that cause some of these people to develop disease and some people not, and maybe inflammation is one of these risk factors. So measuring high sensitivity CRP or interleukin-6 could be ways of trying to figure that out. In this illustration, you see that the Lp(a) particle causes atherosclerosis because, for one, it carries LDL and it has ApoB on it, but this also oxidizes the lipids, contributing more to plaque formations. And it's independently associated with aortic stenosis and atherosclerosis. And it's the #1 inherited cause of familial coronary heart disease. And then it also can cause thrombosis because that little squiggly line, the Kringle repeats there on the side, that has homology to plasminogen. And so it's believed that it inhibits fibrinolysis and can contribute to clots, which is why we think that there's an increased risk of heart attacks and stroke. And we know that Kringle 4 domain 2 that I meant, or type 2, that because that's variable in length, the size of the LPA particle can vary in size. And if you have a lot of repeats, your ability of your liver to get that out into your bloodstream will be diminished because it gets stuck. I don't think they know, but they think it gets kind of stuck. And that causes the blood concentration of LPA to go down. So if that segment is shorter, the body can crank out more Lp(a) and the concentration in the blood rises. Currently in phase 2 and 3 clinical trials, there's a antisense oligonucleotide drug that is going to target Lp(a) and lower it by 70 to 90%. And we believe that unlike LDL cholesterol, where there's a very linear relationship with lowering LDL and cardiovascular risk reduction, you kind of have to get a dramatic shift in lowering of Lp(a) before you begin to see risk. And we have these genome-wide association studies where they have looked at what's the difference in between those that are higher risk and lower risk, and about a 50 milligram per deciliter reduction shows benefit in mortality. So they believe that it at least needs to be reduced by that amount. Currently, we have apheresis, niacin, PCSK9 inhibitors, cholesterol ester transfer protein inhibitors, and mipomersen, which is an LDL oligonucleotide drug. And those all lower at about 20 to 30%. But if you were to lower individuals by 30%, a lot of them would not have that 50 milligram per deciliter reduction that I mentioned. We do know that the heart protection study showed that statins still protected people even when they have Lp(a), even though that they can raise the levels of Lp(a) by 10 to 20%. They still showed protection. And that's probably because ApoB is reduced by a factor of 6, even though Lp(a) rises by 10 to 20%. The European Atherosclerotic Society, they say in select patients, you might want to consider niacin because niacin is cheap and it's easy to get approved for somebody or prescribed for somebody that has this. But the all American societies, they just completely say, we don't have any evidence showing that it helps, like don't use it. I think, my personal threshold is if their levels are 350 nanomolar per liter or greater, why not? Because we're going to potentially have benefit. That would have that 50 milligram per deciliter reduction if we lowered it 30%. So why not give it a try? We have to be careful with niacin with concomitant statin use because it can cause issues there, but up to a gram a day, slowly titrated up over months, that's okay. It's worth a shot. And if they're going to qualify for a PCSK9 inhibitor, I would probably try to do that over a statin if you could, because we do know that those lower Lp(a) instead of raise it. In summary, lipedema is common. It's in 1/10 of women. It's often associated with increasing morbidity, gait disturbance. They'll have this endless diagnostic odyssey of trying to figure out, like, do I have fibromyalgia, or why can't I lose weight? And it may just be something simple. With these rare genetic disorders, we also realize that there are treatable diagnoses right now that we can diagnose in people. And even if we find out that they have a gene mutation that is not yet treatable, there are drugs in the works coming that they may be eligible for. And Lp(a) is a huge risk factor for cardiovascular disease. And I predict in the next 10 to 20 years, it will be the next thing we look at after LDL and ApoB reduction. In fact, I should say after ApoB reduction, because a lot of other like European societies and Canadian societies, they look mostly at ApoB. We're just still kind of behind looking at LDL cholesterol. And making these diagnoses can make such an important impact, even if you don't feel like you're really changing anything as far as like, let's say lipedema, telling them you're not crazy. There is a reason for, you know, your arm being larger or you not being able to lose weight in this certain part of your body. I mean, I've had people Facebook friend me and then like post things about lipedema before. Like they want to tell the world like I have this disease, you know, and they're like proud to finally know what's causing it. All right, and I think that's it. Any questions? No? Okay, all right. Thank you.